conference conducted by Psychiatry Department, Sri Balaji Medical College, and titled Nishi Fields and Innovative Approaches in Psychiatry. And to begin with, I would like to call upon Dr. R. Rajkumar, Professor and HOD of Department of Psychiatry, Sri Balaji Medical College, to say a few words and commence today's event. I welcome you, sir.
Morning. Starting a bit late, my apologies for that. I would like to say a few words before we begin about why we conceived this and we are executing it today. Okay, right. Sorry. I have been in this field for longer than I care, and I've worked in many places, including UK. I've seen our medical graduates going abroad and flourishing both financially and academically, and even in leadership roles. Unfortunately, these people are not being identified and honored as they should be because they have achieved, they have made a mark. So when I had a chance to conduct an international conference on psychiatry, I identified and chose people who had gone from here, from us, and took up psychiatry and flourished academically, professionally, and also internationally. So I've chosen about 4 people, and they'll be presenting their work. The interesting and important thing here is they have worked in the particular fields they're talking about. So they have experienced and also studied and trained in the field they're going to talk about, and that we have wealth of information which may not be in textbooks. And since they are from India, they know what is the local scene, and they will be talking to us where we can learn from that particular experience and profit. So with these few words, I would ask the first presenter to come here and present her topic. Thank you very much.
Thank you for your wonderful words, sir. This brings us to the first event of the day, which is paper presentation chaired by Dr. Padma, Professor and Department of Medicine. Our first presenter for the day is Dr. Apurva Selvaraj. I kindly welcome you, ma'am, to do.
Can you just share the screen? Oh, it is sharing already?
Already shared.
Okay. Good morning. My name is Dr. Apurva Selvaraj. I'm a final year PG here at Department of Psychiatry in Sri Balaji Medical College and Hospital. So as we know, the world has been battling against COVID since almost 2 years, and even India has been affected. And even India has been affected since almost the last 1.5 years. And all of us doctors have been relentlessly working over the last 1.5 years to get rid of this virus from our country, from the world. So that brings us to my topic, which is psychological distress related to COVID-19 among postgraduates of a tertiary care hospital. A little bit about my study. So the World Health Organization has announced COVID-19 to be a global public health crisis. And globally, as of 1st October 2021, there have been almost 23.5 crore confirmed cases of COVID-19, including approximately 48 lakh deaths, which have been reported to WHO. In India, as of 1st October 2021, there have been almost 3 crore 37 lakh 66,707 confirmed cases of COVID-19, with approximately 4.5 lakh deaths reported to WHO. Frontline healthcare workers are among the most vulnerable groups at risk of mental health problems during the pandemic. And we've all been actively involved not only in COVID care, but we're also influenced by various psychosocial factors. So the novelty of the virus, the frequently emerging complications, the catastrophic risks involved in the management, and the high mortality rates have just been an additional psychological burden to all of us doctors, apart from the fear and uncertainty of the pandemic as the general public is facing. So there was a study done on a sample of 769 armed force doctors across the country, in which anxiety and depressive symptoms were seen in 35.2% and 28.2% of the doctors. An online survey done in Wuhan, China, concluded that medical healthcare workers were more prone to developing insomnia, anxiety, depression, obsessive compulsive, and traumatization disorders when compared to their non-medical counterparts. So this study of mine aims to look at the psychological impact, specifically anxiety, the pandemic has had on postgraduates who worked actively in the front line in a tertiary care hospital. So, going forward, the aim of my study is to assess the psychological distress related to COVID-19 among postgraduates of a tertiary care hospital. And the objective was to assess the prevalence and severity of COVID-related anxiety and its symptoms among the postgraduates of a tertiary care hospital involved in managing COVID-19 patients using the COVID-19 anxiety scale. A little bit about the methodology. It's a cross-sectional study which was done in Sri Balaji Medical College and Hospital in Chennai. And the study sample were the postgraduates of this hospital. The sample size was 119, and the inclusion criteria were postgraduates who worked actively during the first wave of the pandemic and the ones who consented to be a part of the study. The exclusion criteria was postgraduates who were not consenting to be a part of the study. And the study was done through an online platform using Google Forms. The instruments that I used were a semi-structured questionnaire, which was used for the demographic details, information on the nature of duty, the participant's subjective description of their mental state, and the symptoms experienced. The COVID-19 anxiety scale is a brief, rapidly administrable, reliable, and validated 7-item instrument which has 2 domains. The first domain being for illness anxiety, which has 2 items, and the second for fear of social interaction, which has 5 items. It has a minimum score of 7 and a maximum of 28, and the scoring is given as less than 13 low anxiety, 13 to 21 moderate anxiety, and above 21 indicating high anxiety. After appropriate statistical test, the p-value was of less than 0.05 was considered to be significant. Coming to my results, as I mentioned, a total of 119 participants, both from clinical and paraclinical branches, were included in the study. And the mean age of the participants was 26.87. We had about 36% males and 64% females in the study. Of the male participants, 18.5% were married, and of the female participants, 22.37 were married. 9.24% participants have a current medical illness, of which 54% have bronchial asthma. So these are the number of participants who were involved in frontline COVID care duties itself. 36.13% of them reported to have done COVID ward duties during the first wave of the pandemic, and the remaining 64%, although they worked during the pandemic, they were not involved in the COVID ward duties. For the sample, this is the nature of the duty that they had done during the pandemic. 52% reported to have direct interaction with the COVID-19 patient or suspected patient for case management. 35% reported to have interacted with healthcare staff who is directly involved in the treatment of COVID-19 patients. And 12.6% reported to have no interaction with COVID-19 patients or staff involved. As I mentioned, the COVID-19 anxiety scale has two domains. So coming to the illness anxiety domain, there are two questions included in that. How frequently are you feeling worried that you have acquired COVID-19, where the mean score was found to be 2.39? And how frequently is your sleep getting affected due to thoughts related to COVID-19? The mean score was 1.59, which was the lowest among all the 7 items. The total illness anxiety score was found to be 3.98. When it came to the fear of social interaction domain, we had 5 items under it. The first item being, how afraid are you of acquiring COVID-19 when going into public, where the mean score was found to be 2.55. And how frequently are you avoiding conversations on COVID-19 related information out of fear and anxiety? The mean score was 1.76. How afraid are you of acquiring COVID-19 when an unknown person is coming closer to you? The score was found to be the second highest, which was 2.84. How anxious are you on when you get to know information on COVID-19? The mean score was 2.2. And the highest scored item was, how concerned are you when people cough or sneeze because of the fear that you may acquire COVID-19, where the score was found to be 3.18. The total fear of social interaction score was found to be 12.53. So the total anxiety score based on these two domains was found to be 16.51. Based on the cutoff for the scale, we had 2.5% of the participants, which is only 3 participants who reported of no anxiety, 13.5% reporting of high anxiety, and another 13.5% reporting of low anxiety. The maximum was found to be moderate anxiety, which was about 70.5% of the participants. Okay, so when I compared the total anxiety scores across the genders, females were found to have a higher total anxiety score of 17 when compared to males who only had 14. And this difference was found to be statistically significant. We had asked the participants to give a subjective description of how they were feeling at the time of the study, and 5 subheadings were given to them, subcategories. Feeling okay, worried and afraid, sad and frustrated, bored, lonely and tired, and longing for normalcy and feeling hopeful. So of these, those who mentioned to feel sad and frustrated and worried and afraid had higher total anxiety scores compared to the others. And this difference was also found to be statistically significant. Participants were given a checklist of all the symptoms that they had been experiencing over the last 2 weeks at the time of the study, and which could be grouped as physical, psychological, both and none. So of these, those who reported to have both physical and psychological symptoms had higher total anxiety scores when compared to those having psychological and physical symptoms. So in my study, 64% were females and 36% were males. Majority of the study sample was single. Out of the 119 participants, only 36% were involved in frontline COVID ward duty at the time of the study. The total anxiety score using the COVID-19 anxiety scale was found to be 16.51. So 70.58 of the study population had moderate levels of anxiety, and 13.5 had mild, and 13.5% had severe levels of anxiety. Females had a higher total anxiety score when compared to males, and this has been found, the similar results have been found in another study which was conducted among 777 Indian doctors and some other studies. When their subjective experience was related with COVID anxiety scores, total anxiety score is higher among people who express sadness or frustration and being worried or afraid. Persons who had higher anxiety scores had both physical and psychological symptoms, followed by those having only psychological symptoms. And approximately 30% of the participants reported of having no typical symptoms of anxiety. To conclude, this study is the first of its kind, which assessed the psychological impact among postgraduates only during the COVID pandemic. And varying levels of anxiety were found to be present in the postgraduates who worked in the front line during the pandemic. So it is essential that the mental health of the healthcare workers which often gets neglected, should be the primary focus during such a time of crisis. Early screening and implementation of psychological interventions is essential for improving the mental well-being of healthcare workers. The limitations of my study are it's a cross-sectional study, and the sample included was only postgraduates, so the results could not be generalized. And as I came to the end of the study, I realized that for assessing the depressive symptoms, standardized scales could have been used. These are my references. Thank you.
I take an immense pleasure from the Department of Psychiatry. We cordially invite Dr. Sharma, Professor and Department of General Medicine. We welcome. Next.
Okay. Excuse me. Good morning to one and all. I am Dr. Anchal Niglani from the Department of Psychiatry, Sri Balaji Medical College and Hospital. And today I'm going to talk about a case of acute psychosis with DRESS syndrome. So, a little introduction about what is DRESS syndrome. So DRESS syndrome is drug reaction with eosinophilia and systemic symptoms, which is a severe adverse drug reaction. So drug reaction with eosinophilia and systemic symptoms, it is a severe adverse drug reaction, which is generally, the incidence being 1 per 5,000 to 10,000 drug exposures. So the term DRESS was given by Burke et al. After going in 1996, and it has a high mortality rate of around 10%. The most common medications leading to DRESS syndrome are anticonvulsants, the main culprit being carbamazepine, and the other important one being allopurinol, which is the most important one causing DRESS syndrome. So DRESS syndrome, as we know, is a complex syndrome with a broad spectrum of clinical features. The manifestations are generally delayed, which occur after 2 to 8 weeks of continuing the drug. The common signs and symptoms include fever, rash, lymphadenopathy, and multi-system involvement. The most common being the involvement of liver, leading to hepatic necrosis, or kidney involvement, or cardiomyopathies. And the most common hematological findings are eosinophilia and atypical lymphocytes appearance. And deranged liver function tests are the most common things. So here we had a case, Miss X, a 16-year-old female who presented to the OPD, single, educated till 12th standard, unemployed, and reported to the hospital with her mother with complaints of behavioral disturbances, aggression, and restlessness since a period of 1 month, which had been aggravated for the last 2 days. She also came with dermatological complaints of itching all over her body, small vesicles over her face, fatigability, and fever, which progressed to erythematous macropapular rashes within the next 2 to 3 days, peeling of skin all over her body, and conjunctival congestion associated with swelling of lips and eyes. So the patient So the treatment history of the patient involved behavioral disturbances for a period of 1 week, for which the patient sought treatment from a private psychiatrist, and she was initiated on carbamazepine 400 mg, olanzapine 10 mg, chlorpromazine 500 mg, trihexyphenidyl 2 mg, and nitrazepam 10 mg. Her personal history and family history was not significant, and her pre-morbid personality was of a well-adjusted patient who was average in her scholastic performance and extroverted in her nature. Her general examination and mental status examination revealed pulse rate of 123 beats per minute. There was persistent tachycardia, a low blood pressure of 90 by 70 millimeters of mercury, and body temperature of 100 Fahrenheit. Her mental status examination revealed that she was uncooperative for a detailed psychiatric evaluation at the time of index contact. The patient was restless and irritable. Her appearance was moderately kempt and appropriately dressed. Eye contact was not made. Rapport was difficult to establish with her. The psychomotor activity was increased. She was talking irrelevantly and incoherently. There was echolalia which was present. The affect was irritable with no lability of mood. The thought and perception of the patient could not be assessed at the time of index contact. Her hematological investigations revealed an ESR of 25, with the normal range being between 0 to 12, an eosinophilia, which is a known presentation of DRESS syndrome, of 18.4, and the normal range being between 0 to 6%, an absolute eosinophil count of 5,050, the normal range being between 450 and 550, a lymphocyte count of 13.3%, and alkaline phosphatase levels, which were raised, being 249. And as we know, deranged liver function tests are a known presentation of DRESS syndrome. So the pharmacological diagnosis of the DRESS syndrome was made and the culprit drug being carbamazepine or chlorpromazine, because the symptoms were present on the 27th day after initiating the treatment with the drug. The pharmacological management involved immediate stopping of the psychotropic drugs, except for olanzapine. The dosage of olanzapine was adjusted, and olanzapine was started with a minimum effective dose of 2.5 mg, and a benzodiazepine was added for irritability and sleep disturbance. That is lorazepam 1 mg. The patient was also initiated on treatment with injection dexamethasone, ranitidine, and cefotaxime for her DRESS syndrome. And the vitals were monitored once every 4 hours, and hydration was adequately maintained, and antipyretics were administered for her fever. So on eventual follow-ups, and on the 3rd day of a follow-up, the patient's mother reported of persistent behavioral and sleep disturbances. So the dosage of olanzapine was gradually increased and titrated within the next 5 days from 2.5 mg to 7.5 mg. And the dosage of lorazepam was also increased from 1 mg to 2 mg. And for the treatment of DRESS syndrome, the steroids, the antibiotics were continued for a period of 10 days and 7 days, and the steroids were tapered off and stopped eventually. And also, we had to keep in mind that the patient was having behavioral disturbances, and the administration of exogenous corticosteroids is known to induce or exacerbate psychotic symptoms. So the psychotic symptoms were to be kept at a watch while giving her injection dexamethasone. So over a period of 7 days, the patient's dermatological lesions and systemic manifestations gradually disappeared. And the management of Rett syndrome in this case was the line of recommendation. So there was no cross reaction or reappearance of the dermatological symptoms after increasing the dosage of olanzapine, and the dose of olanzapine was maintained at 7.5 mg per day. The patient maintained improvement in her psychotic symptoms and was subsequently discharged from the hospital. So with this, we would like to conclude and bring to your attention about the possible adverse effects of carbamazepine, which is most likely to cause Rett syndrome. And she was also on chlorpromazine, which is also known to cause cutaneous manifestations. We are unable to identify the drug which was responsible for the side effects, as she was on a combination of chlorpromazine and carbamazepine both. So with this, we would just want to promote efficacious use of drugs to prevent such severe adverse reactions. Thank you.
I would like to call upon Dr. Madhumita.
Okay. Good morning to one and all present here. I'm here to present a study that was conducted in the Department of Psychiatry in our hospitals, Sri Balaji Medical College and Hospital. So my study was on a study to assess the symptom progression and treatment adherence in individuals with psychiatric disorder during the COVID-19 pandemic. So, as we know, COVID-19 pandemic is having a negative effect on the society's mental health. Both the pandemic and the measures taken to combat the pandemic have also shown some negative effects on the general public's mental health regarding the starting misinformation about the pandemic situation and the accompanying panic surrounding it. And hence, the COVID-19 pandemic is an emotional challenge in the general population, and more so in the individuals with prior history of psychiatric illnesses. And the social isolation and lockdowns can negatively affect the mental health status of these individuals. Lockdowns have shown to increase stress, anxiety, and depression in general public. And this has occurred previously in other pandemics like the outbreak of swine flu in 2009, Zika in 2015, Ebola in 2014. According to earlier studies, individuals with pre-existing psychiatric disorder perceive more stress and anxiety and depression than the general public. So the objectives of the study was to find change in symptom severity during the COVID-19 pandemic and the relationship between the symptom severity and compliance to the drug. So the study type was a cross-sectional study. It was done among 65 patients. It was a convenience sampling. Study population was outpatients with diagnosed psychiatric illness and substance abuse on regular follow-up in psychiatry department of Sri Balaji Medical College and Hospital. The inclusion criteria were participants should have been diagnosed with any psychiatric condition and must be enrolled in the psychiatry department of SBMCH on or before March 2019, so that we would have an adequate 1-year period before the onset of the pandemic. and the participants should have at least 50% of the follow-ups in defined time frames, which I'll be talking about in the next slide. Patients of the age group 18 to 70 years are included in the study, and patients who are willing to participate in the study. Exclusion criteria were individuals with intellectual disability, patients with debilitating illness, and the inability to communicate in Tamil or English. So the tools used for the study were a semi-structured proforma, which was used to collect the basic socio-demographic details of the individuals and other relevant clinical data, and a scale which was used to measure the symptom severity, which was the Clinical Global Impression and Severity Scale, CGIS. So individuals with a history of psychiatric illness who were following up in our OPD, who fulfilled the inclusion-exclusion criteria, were included in the study. A semi-structured proforma was first applied, and it was used to collect the basic socio-demographic details and the clinical variables. Then by going through the patient's follow-up records, the timelines were divided into T1 and T2. So March 2019 to March 2020 was considered as T1, and March 2020 to March 2021 was considered as T2. The T1 and T2 includes the 1-year duration before and after March 2020 respectively. The defined time frames are taken pertaining to March 2020, as WHO declared COVID-19 infection as a global pandemic in 11th March 2020. Symptom severity is measured using the CGIS scale, which was scored retrospectively by reviewing the patient's follow-up records in the defined study period, and the mean CGIS score of T1 time frame and T2 time frame was taken for further analysis. Results. The sample were of 65 patients, which had 47% of males and 53% of females. The mean age of the sample was 33 years, plus or minus 11.69. Majority of these sample population were married, that is 63%, and they belong to the lower socio-economic class, which was 49%. The classification of socio-economic status was done using modified Kupusamy scale. The mean duration of illness among the sample population was 6.72 years. So on seeing the symptom severity, we can find that the symptom severity after March 2020 was significantly higher than before March 2020, with a p-value of 0.001. Here in this table, we can see that in the T1 time frame, that is 1 year prior to the onset of the pandemic, we can find that the mean ranks and the mean of the symptom severity were comparatively lower than the T2 time frame. Change in the symptom severity among various psychiatric illnesses. So on taking the various psychiatric illnesses that was presented during that time frame to us, we found that the neurosis patients had significantly higher symptom severity after March 2020 than before March 2020, with a p-value of 0.026, and affective disorder being the next, but it shows a trend towards significance, but it does not come under a statistically significant. Compliance. Significant number of individuals became non-compliant with treatment in the immediate 6 months after the March 2020. This becomes an important factor as the pandemic situation also contributed to it. And here, when comparing the D3 time frame, that is the immediate 6 months after the onset of the pandemic, the time period was March 2020 to August 2020. We can find that the non-compliance among the various diagnosed psychiatric illnesses were more when compared to the other time frames. And even after the pandemic, even 6 months after the pandemic has started, that is after September 2020, the compliance was rather returning back to the pre-pandemic state. So during the pandemic situation, the perceived caregiver burden was found to be significantly associated with the symptom severity. And further, we could also demonstrate that the caregivers of individuals with higher symptom severity had higher perceived caregiver burden with a significant p-value. Discussion. Symptom severity, which was measured by a change in the mean CGI score, showed an evident worsening of symptoms. In previous studies, which was done in China and in Denmark by Havo et al. And Lassivol et al., showed individuals with neurosis and mood disorder both were found to be symptomatic after the onset of the pandemic. Whereas in our study, we found a significant, statistically significant value only for neurotic patients. And this explains the picture where we found a trend towards significance in the affective disorder patients. So in the study, the worsening of symptoms were found to be significant in neurosis patient, but the affective disorder shows a trend towards worsening. Compliance. Significant number of individuals became non-compliant with treatment in the immediate 6 months after the March 2020, that is the onset of the pandemic, compared to the other time periods, ranging from 29.5% to 32.3%. They become non-compliant. The reason for this non-compliance could possibly be due to the lockdown during the pandemic and may not be directly attributed to the COVID pandemic, as we could not find any significant difference in the treatment compliance during the September 2020 to March 2021, that is the later half after the pandemic has started, when compared to the pre-COVID time periods. So they were gradually returning back to normal. It is substantiated by a quantitative report from individuals that 36.9% had missed regular follow-up due to non-availability of transportation during the COVID-19 lockdown period. It was observed that during the pandemic situation, the perceived caregiver burden was also found to be significantly associated with individuals who were symptomatic. So to conclude, we could demonstrate that the individuals suffering from psychiatric disorder had a significant worsening of symptoms since the COVID-19 pandemic. Further, the other scopes for this study is we can compare, we can try to find if any exact reason is there. If there is any one particular reason, it could the further scopes of the study it can be taken in that way. These are my references. Thank you.
Thank you.
Good morning. So today's topic is wellness, well-being, and coping styles used by interns working in a tertiary care hospital during the pandemic. So as previously, my other speakers have spoken about the mental illness aspect per se, I took a different approach of analyzing the psychological well-being. There were a group of interns who were posted at a time which was uncertain. So we wanted to know how they were. They were able to cope, but were they well? Can we call them well mentally? So before that, I would like to introduce the concepts of what I'm going to talk about. First one being wellness. All of us know the WHO definition, but that is a little not fulfilling the current needs. I found this better explained by the National Wellness Institute, where it is defined that wellness is an active process through which people become aware of, and make choices towards a more successful existence. And it is based on three tenets. Wellness is considered a conscious, self-directed, evolving, achieving process. Wellness is multidimensional and holistic. It is a lifestyle, and it includes spiritual and the environment. And wellness is positive and affirming. So next, coming to the dimensions of wellness. So here we started with the 3 dimensions. We have the 6, we saw the 16, but we will stick to the 6th dimension of the wellness model, which include physical, social, intellectual, spiritual, emotional, and occupational. So physical, of course, defines the development of a physically well lifestyle, which includes good exercise and eating habits. The social wellness includes the social dimension, which encourages contributing to one's environment and community, and it emphasizes the interdependence between others and nature. And occupational, this recognizes personal satisfaction and enrichment in one's life through work. Emotional, this aspect recognizes awareness and acceptance of one's feeling. Intellectual, this dimension recognizes one's creative, stimulating mental activities. And spiritual, which defines the search for our meaning and purpose of existence. Now, wellness is one concept, but many don't know that well-being is different from wellness. So well-being is not just physical health. It takes into account the entire body, both mind and the physical aspect, and is not just the absence of an illness. The approach to health includes a positive mental state of emotions and moods. So well-being is perceived as more of a positive psychology, a positive attitude to developing a more happy life, which includes all domains. So the theory of well-being. So this is a gist of the theory, which is called PERMA, the acronym, where P stands for the development of positive emotions, E stands for engagement, R for positive relationships, M for meaning, and A for accomplishments. So positive emotions include increasing more positive emotions, that is, seeing your life in the past and the future in a more positive way, in a more affirming way. And engagement, that is finding activities that put you actively involved and which make you elevate your state of well-being. And relationships, the pursuit of healthy relationships that offer a sense of belonging, meaning one's exploration into one's own separate journey. Accomplishments, to pursue achievements, competence, success, and mastery for its own sake in a variety of domains. Now, coping. So coping is typically defined as the effort to prevent or diminish threat, harm, and loss, or to reduce the distress that is often associated. It is a directive towards reducing the negative emotional consequences, and coping mediates between antecedent stressful and distressing consequences. A coping style is a typical manner of confronting a stressful situation and dealing with it. And we have basically 3 major coping styles. One is task-oriented, emotion-oriented, avoidance-oriented. So this intro was very much needed so that I can start presenting the paper that we did. So the aim of our paper being the study of psychological well-being and coping skills of interns during the pandemic, and to assess the correlation between psychological well-being and the coping styles that they adopted. Our objectives were to study the well-being, to assess the coping style, and to analyze the correlation. So why did we need to do this study? To provide adequate support to the juniors who are suddenly faced with an uncertain situation, which we were even baffled with. It is all the more important in the time of uncertainty, such as a pandemic. They faced the situation of getting infected and facing the consequences while working, and fear and uncertainty in them led to stress and them adopting maladaptive coping strategies. Suddenly they face a stress, and if they start now developing a maladaptive coping strategy, as we call it, or like take up a substance or just to relieve the stress, this habit will become a behavior and eventually continue. So to provide an insight into what was happening, methodology, it was done in a tertiary care teaching hospital for a year. The cross-sectional study of survey between two groups, a batch of interns in the 2014 and 15 batch, and group B, the 2015-16 batch. The sampling was done on convenience. Whoever consented, their data was collected. The tools used. So we had a basic demographic detail of their name, age, and their residence. The tools that we primarily used, being a questionnaire-based study, the first tool we used was a RIF scale, developed by RIF. It is a psychological well-being scale. We looked into only the psychological domain, psychological well-being domain of these people. So this was a multidimensional model of psychological well-being. The dimensions being autonomy, the sense of self-determination, environmental mastery, the capacity for them to effectively manage one's life and surroundings, self-acceptance, positive evaluation of oneself and one's past life, personal growth, sense of continued growth and development, purpose in life, the belief that one's life is purposeful and meaningful, positive relations with others, the possession of quality relation with others. And the second tool that we used was brief COPE. Here COPE stands for coping orientation to problems experienced inventory. So here the questions are framed in such a way that two styles of coping, they fall under two subdomains. One being the avoidant, the next being the approach. So we had 40 interns in each group. The sample size was 80. On statistical analysis done on both groups on the basic details of age, gender, and residence, we didn't find any major statistical significance. On comparison, the RIF psychological well-being, we found a more positive well-being in the domains of autonomy, personal growth, purpose in life, and self-acceptance in the group B compared to group A. In the aspect of coping, both groups coped well, but group A used more of an avoidant coping style compared to the second group, which used more of an approach-based coping. So this is the statistical results of each domain: autonomy, group A, group B, group A being the batch which faced the virus in the first year, group B after the vaccination and adequate knowledge was provided to them. And we did a comparison gender-wise for the coping methods. The conclusion was genders did not show any statistically significant changes in the coping methods. In the coping style, we compared both the groups A and B, and we found that the first group, group A, had more of an avoidance coping style compared to group B, which had more of an approach-based coping. Now we took up their well-being, and we wanted to see whether their well-being had an influence on their coping methods used. So we had 80 students. So we ran a Spearman's correlation. On the total scores, we didn't find any significant association between their well-being and the brief course. But when we looked into the domains, when considering individual domains, significant negative correlation was observed between autonomy, personal growth, purpose in life, and self-acceptance with avoidant coping. Whereas the domains of autonomy, personal growth, and self-acceptance showed a significant positive correlation with approach. So this says basically coping has an effect on well-being and vice versa, statistically. This points to the fact that as self-oriented positive aspects of well-being increase the coping style, adopted this approach, but in case of decline, avoidant coping is more seen. So these were the results of the groups classified as avoidant and approach. So what was the conclusion? A study was conducted to determine how students who are faced with a sudden adverse event with uncertainty and stress were able to cope and how it affected their well-being under different domains. No major difference in well-being were observed based on gender, age, or residence, but we were able to infer that the domains of autonomy, personal growth, purpose in life, and self-acceptance was more in the second group, than the first group. On comparison, the coping methods used between the first batch and the second batch, the first had more of an avoidant coping style, while the second had a more approach-based coping style. I would like to extend my deepest gratitude to co-authors, Dr. R. Rajkumar and Dr. Lakshmi Prabha. I would like to thank Dr. Ankan Paul for his help with the statistics, and I would like to extend special thanks to Dr. Priya, Dr. Gopinath, and Dr. Farhana, and my colleagues in the Department of Psychiatry for their guidance and inspiration. These are my references. Thank you. Any doubts?
Now I would like to call upon Dr. Ankan Paul to give the talk.
Am I visible and audible as well? So good morning to all of you. I'm Dr. Ankan Paul, consultant psychiatrist, Samana Manohar Hospital. And with the permission of my co-authors, Dr. Lakshmi Prabha, Dr. Priya Shivshankar, and Dr. S. Nambi, and the esteemed chair, I would like to bring forth to you the study that is the prevalence of depression and its correlates in caregivers of patients undergoing periodic hemodialysis. So just going into the brief introduction about the study, as we know, depression is a common mental health problem. It consists of low mood, loss of interest, lack of pleasure, feelings of guilt, sleep and appetite loss, and so on. So caregiving is any form of help, aid, assistance which is provided to any person who requires it. And when we speak about caregivers, in general, we refer to non-professional or family caregivers. A significant amount of energy and time are spent by caregivers, amounting to years of life being lost in it. So there is a concept of caregiver burden, which has been described as the impact on physical, social, emotional, and financial well-being of the person. And this burden is continuous and can lead to depression, especially in the case of CKD, which is a very complex entity. The complexity surpasses that of many other medical conditions. And that is why caregiver burden in caregivers of patients who are undergoing hemodialysis is significantly high. So our study was aimed to assess the prevalence and to assess the severity of depression in caregivers of patients who are undergoing hemodialysis and to bring forth what are the socio-demographic factors associated with it. Going briefly into the materials and methods, there was a cross-sectional study which was done in the Department of Nephrology of Sri Balaji Medical College and Hospital. Study period from December 2018 to March 2019 with sample size of 60, calculated using Hawkins formula, and we followed sequential sampling. So inclusion criteria wise, the family caregivers of the patients who were given consent and who were over 18 years of age were included. Caregivers under 18 years and who had any previously diagnosed psychiatric disorders were not included. We had designed a basic demographic proforma, and we also used a Hamilton Depression Rating Scale, which is a very well reliable and validated scale. So data was analyzed using MS Excel, bar graphs were used to express the distribution, and for Fisher exact test was performed for differences in distribution between two or more categories. The p-value of less than 0.05 was considered as significant. These were the steps of the study. We sought approval from the Institutional Ethical Committee. Informed consent was obtained as told. Socio-demographic details were collected by the basic demographic proforma designed by us. Hamilton Depression Rating Scale was administered, statistical analysis of the data was done, and results were obtained. So very briefly into the results, as we can see, gender-wise, we see that 38 participants were females and 22 were male. And age-wise, the highest number of participants, 29, came from the age bracket of 45 to 60 years. Relationship-wise, 41 spouses had registered as participants. Caregiving period-wise, most of the participants, 31, were from caregiving period of 0 to 5 years. And 38 participants did not have any physical morbidities compared to 22 who had one or the other physical morbidities. So this is about the data analysis of prevalence of depression and its severity, as you can see. And we can see the mean score on HDRS, Hamilton Depression Rating Scale, turned out to be 7.766 plus or minus 1.375. But that does not portray the complete picture. For that, we have to come to this distribution where we actually see that in terms of significance, gender was significantly associated with severity of depression and also the presence or absence of physical morbidities. Now, as we have already mentioned, that the mean HDRS score was 7.766 plus or minus 1.375, but 18.33% of the participants had scores implying moderate to severe depression. In comparison to this, a study by Shukri et al., which was done in Iran, had 52.40% of caregivers having moderate depression and another 3.8% had severe depression. So we can see that in the Indian context, the numbers have been a little lesser. As we have mentioned, statistically significant association was found between gender of caregiver and severity of depression. So in the general populace, we already know that women are more likely to suffer from depressive disorder throughout their lifetime, and maybe presence of a higher level of caregiver burden in females can make them more vulnerable. Whereas statistically significant association between presence or absence of physical morbidities can be explained by the fact that it is very difficult to cope with health issues once you are already burdened. You don't have enough time to dedicate to yourself. Whereas it is also possible in case of disorders like diabetes and hypertension that they may itself lead to depression. Those are my references. I would like to end with a quote. There is caregiving often calls us to lean into love we didn't know was possible. Thank you.
This concludes today's paper presentations. We would like to extend our gratitude to Dr. Padma ma'am, and any questions from the audience and participants too. I request Padma ma'am to give any input, sir.
All the post graduates resonate really well, and it was a wonderful presentation by this graduate. So, all the best for your future. Thank you. And thank the Department of Psychiatry for giving me the opportunity to chair the session.
We have a function which is starting at 10 a.m. Prashant. Banner in the page. On the banner, typically put screen share back level, double WhatsApp image.
2004. He left immediately after, went to UK and got his MRC Psych at the first attempt and did MSc in neuroscience from Birmingham University, and then he has now moved on to Canada to be the medical director of a prestigious institution in Vancouver. His area of interest is actually old age psychiatry, and then he specialized in drug and alcohol dependence in old age, and now he has progressed on to studying the brain damage that occurs due to drug called cannabis and alcohol use, which he has made tremendous strides. I have personally requested him to honor us by taking part in this conference. Dr. Hari Subramaniam is an old age psychiatry, basically from Chennai, but he did his medical course in Bombay, now Mumbai, and he moved on to a place called Leicester in England, where I had the opportunity to work with him, or he worked with me rather. And he has been studying a particular niche area called capacity assessment in the elderly, which has got a tremendous legal and administrative significance. He has worked in this area for really about more than 15 years to my knowledge, because he was working from 2007 and now it's 2011. And I had interacted with him on many occasions, and he is keen in communicating his knowledge to us. And so I've chosen him to give a talk today. Dr. Ramesh, who was my student again, and had got his MBBS from Tirunelveli Medical College and DPM from Institute of Mental Health, Chennai, where he was a student of mine. He went to Birmingham in England and got his MRC Psych, and now he's working in Lincolnshire as a consultant. He's also the clinical director of the Lincolnshire Partnership NHS Trust, where he's been making a great mark. He's going to talk about the physician burnout during COVID, which is a relevant and a current topic to us. And Dr. Ananta, he's actually from Andhra Pradesh, but did an MBBS, MD, DPM and MD from Bombay, where she'd been a meritorious student, gaining first rank in all her exams. She had gone to UK and did her MRC Psych and has done tremendous work in child and adolescent psychiatry. She's, apart from psychiatry, has been an advocate for the Black and ethnic minority in UK, where she's been representing this particular group of people in government, in public, and also in administrative academic endeavors. She is a brilliant student, a fantastic teacher, and I have requested her to communicate us about her knowledge in suicide in young persons, which is a very, very stressing and vexatious problem in our country also. If you see the incidence of suicide between 18 and 24, it's tremendously high, and that is taking away people at the bloom of our youth, which is a crime actually, and we don't know what to do with it. And she's going to share the knowledge with us, apart from talking about self-harm in youngsters. And we have chosen these people so that they can give us their experience in this niche field. Now I would request our Dean Sir and the other dignitaries to give their blessings to us. Thank you very much.
Respected and beloved advisor, respected medical superintendent, Professor Shashi Kumar, head of the Department of Psychiatry, Professor Raj Kumar, heads and senior colleagues, and dear students. It gives me great pleasure to be here this morning as we are halfway through the international conference in psychiatry with a theme niche in the field of psychiatry. Now, over the past 1.5 years, almost everybody is stressed, and the need for the psychiatrist is increasing day by day. As Professor Rajkumar was mentioning, the psychiatric derangements lead to suicidal tendencies, and it is a problem even today. So you people play a very crucial role in addressing the other side of man, the physical aspect. It is at least easy to diagnose and manage, but what you are doing and dealing is a real challenge. And as he was mentioning, some of the students who have studied here are excelling in the field of psychiatry. To name, Dr. Sundar was a first batch student here in 2003. He has made a mark in the field of psychiatry. And I wish all the students doing graduation and post-graduation here in Sri Balaji would also become shining stars and be of use to the society in handling this crucial healthcare delivery. With these few words, I congratulate the team for taking efforts to organize this wonderful conference, and thanks to all the invited speakers for coming forward to share the knowledge. Thank you very much.
Thank you, sir. Now I would like to invite our advisor, Veerababu sir, to give us some more sample.
Respected Dean, Professor Johnson, respected Medical Superintendent, Dr. Saji Kumar, HOD of Psychiatry, Dr. Rajkumar, Dr. Priya, Dr. Lakshmi, my senior colleagues, visiting professors, my dear students. I am very happy to be here to participate in the psychiatric conference of our Department of Psychiatry. Only thing is, I am very much disappointed to see the stalls are very empty. I'm sorry, usually I don't give a wrong comments, negative comments. This I should do it. I don't see any professor of medicine, assistant professors, or the PGs of medicine. In the PG studies, one or two questions only on psychiatry. Nobody is here. I don't know why. All the final years also should attend. And we never knew, you probably people, you are ignorant, that 40 to 50% of patients, of your patients today are psychiatrically oriented, psychiatrically healing. Unless you know the psychiatry well, you cannot treat the patient 100%. And especially among women doctors, 5% of women doctors are psychiatrically healing even today. And suicidal is more in the women doctors than are men. These are practical points which I thought I'll talk very freely today. I'm disappointed. I'm sorry to tell you. I'm sorry for the people who have attended, and kindly see in future the HOD to take a strain to meet all people and invite them for their good. Because conference is not, this is an elevated level, not a class to class, not a clinical discussion, not a ward round. The people who have the experience of 20 to 30 years talking about the knowledge to you, for which we should understand. Kattale, Kattal, Andre. Psychiatry is very important subject, and also is going to be a rule in medicine department, in the medical studies. And also, unfortunately, there is no examination on psychiatry in our system. I do not know the other universities. MCA doesn't prescribe psychiatry as a subject or as examination. It's the right time MCA or any other body should recommend psychiatry as a pediatric examination. All the subspecialties should be there. The only people take interest. The people want some deep examination, a good deep student. And in future, the people here should try to get the psychiatry as an important subject and examination point of view. Then only we study because psychiatry is very important. As important as cardiology, as important as neurology. Probably people do well are aware of it. And I am very glad that at least few people understand. Jesus Christ told about Christianity only for 8 people. And he sent all his wishes to all over the world, only 2,000 years ago. Today, Christianity is largest religion. Like this, people here going to got psychiatry important for these few 10s and 20 people. That's enough to spread all over India, all over the world. With his few words, I wish the conference should go on very well and we learn much more than we know right now. Thank you very much.
Our medical superintendent, Kumar sir, to speak a few words on the conference.
Good morning, everyone. Respected Dean, Dr. Johnson sir, Advisor sir, HOD of Psychiatry, professors and HODs of various other departments, and my dear students and the faculties of this college. It's an immense pleasure to participate in the inaugural function of the International Conference on Niche Fields and Innovative Approaches in Psychiatry. Actually, as advisors also, we have two components of any patient's health, the mental health and the physical health. The amount of importance, the physical health, the mental health was not received all this while. If we suggest few years back also, if we suggest somebody, suggest them about psychiatric counseling or anything, it is considered as a taboo. If you are referred to a psychiatrist, they feel they are being degraded or insulted, that sort of thing. That sort of mentality was there a few years ago. But psychiatry has progressed leaps and bounds. There are multiple departments in psychiatry which has come here, say child psychiatry, adolescent psychiatry, so many departments have come here. So the niche fields and the innovative approaches in psychiatry, these are all going to help them. So with the advance of knowledge and social cultures, the need for mental health is slightly, the need and the problem in the mental health has to be addressed. The awareness in public is growing. So the duty of the psychiatrist becomes more now. It becomes with the rapidly growing socio-economic condition of the country, India is progressing to going to be a superpower in few years. So all these things put added stress on the work, and definitely the COVID pandemic is putting a stress on many people. So this field is a growing field. It has a lot of scope for growth. I would suggest the students to take up this field also. I congratulate the organizing team led by the Professor of Psychiatry for organizing the excellent conference, and I also welcome all the international speakers and the national speakers who are going to speak on this conference. I wish the conference a great success. Thank you very much.
I take an immense pleasure to invite all the dignitaries on the dais to release the Swadhyaya for the conference. Thank you, sir.
Lakshmi, what are thanks?
Thank you, Johnson sir, Veerapadu sir, Sasikumar sir, and Rajkumar sir. Thank you very much for sparing your time and coming to inaugurate this inauguration of the conference. And we look forward to having you join us for the rest of the conference. Thank you very much, sir.
I think Shala will be there.
We'll start the international sessions now with Dr. Ashok Krishnamurthy, whom I was talking about a few minutes ago, has joined us to deliver his lecture on the cannabis and alcohol-related brain damage, assessment and management. I think it's important but a niche field. I hope you'll be benefited by this. Thank you very much. Now I call Dr. Ashok to present this talk. Go ahead, Ashok.
Yeah, thank you, sir. Are you able to hear me okay?
Yes.
Okay, thank you. I will be screen sharing my presentation, sir. Just can you check if it is coming out okay?
Yep.
Yeah, is it coming in okay, sir?
Okay, thank you.
All right, thank you. Is it okay for me to start?
Please.
Okay, thanks. Thanks a lot to Rajkumar sir for giving me this opportunity to talk, to come back and talk to the city where I got trained. Again, it's a great opportunity, and I'd love to have more of a discussion rather than a unilateral presentation for today. I'm Ashok Krishnamurthy. I trained in Chennai and under Rajkumar sir's guidance. I worked in UK and then I moved to Vancouver now. I work for Vancouver Coastal Health Authority. As Dr. Rajkumar sir pointed out, my training background is in geriatric neuropsychiatry, but I have subspecialized into addiction psychiatry, and I also do a few other things like younger people with dementia, Huntington's disease, and all the other areas which which are my niche areas of interest. But today I'm mostly going to talk about alcohol and alcohol-related brain damage. Maybe on another occasion, the topic of importance about physician burnout, physician mental illness, and suicide in physicians. It's an extremely important topic as it was highlighted. So I also chair the physician health program for the province of British Columbia here in Canada. So I would be more than happy to chip in to support any work with regards to supporting physician colleagues with regards to mental health and overall wellness and burnout prevention. Without further ado, I would like to move on to the presentation as it is. Again, I did not specifically put a lot of learning objectives, mainly because usually I run this session as a workshop, which usually goes for about 2 hours to 3 hours. That's why I've got, I would say 1 2 minute slides. So I would be skipping some of those, but feel free to use the slide deck to have discussions locally. The most important thing I always do when I try to do this presentation to different audience, I not only do this for psychiatrists, I go around and talk about this to people who do pure addiction related family practice. I do this talk to people who are doing internal medicine. You would be surprised to see that I have spoken to a lot of emergency room physicians as well, mainly because many of these patients might touch down in casualty and emergency medicine, where these things, the understanding of the addiction as a form of a brain disorder is often lost, and they don't get the actual continuity of care. So I try to keep my learning objectives for this, what I want to get across, very simple. I want to introduce the addiction as a brain disorder, which most of us know, and most of us would agree with that. I'm keen to make you, I'm trying to impress upon you to think of it as a model neuropsychiatric disorder, mainly because that will help you to realign your approach towards treating this a chronic remitting and relapsing disorder. Like, I'm sure most of you would agree with that. You don't necessarily come and treat once and then fix the problem and they get on with their life. Also, to address some of the key important aspects of neurocognitive issues in moderate to severe addiction, because the shift of understanding the addictive disorders like substance use disorder has changed quite a lot in the last 10 years. If you look at it, we always talked about nucleus accumbens and impulsivity. There is a lot of movement away from that as well when it comes to moderate to severe addiction. And also, just to make sure that when you go out of this talk today, to appreciate a psychosocial rehabilitation model as how you would think about rehabilitation after a stroke. How would you think about rehabilitation after a brain injury? More of a psychosocial rehabilitation approach with some prospective supportive medications. I think most of these medications are available in India as well, to try and use the combination for this specifically a neglected population with a huge problem. So if you look at it, how relevant it is to India, it is relevant to the whole world, but it's a population which is still probably, if you look at the data across the world, and it includes India as well, it's a single major substance use. Alcohol is the single major substance which has the maximum healthcare expenditures, maximum impact on hospitalization and disability. It's again a hidden problem, and the movement towards younger people using substances like cannabis and alcohol is growing, as is the problem of alcohol use issues in seniors, meaning older people. But when you talk about moderate to severe substance use disorder, the brain of a 55-year-old would look like a brain of a 70-year-old. So that's a kind of a concept I am trying to impress upon. Again, preventative aspects, often we talk about it, and many times they may not touch down with psychiatrists when there is a prevention it's an opportunity. So they might be seeing a general physician, an internal medicine physician, or an emergency room physician, where often these issues are overlooked and not necessarily adequately addressed upon. So that's what I'm trying to talk about, as well as social support. Obviously, the changing family structures and more nuclear family systems. The population in India would also be going along with how much of a limited social support is available in Western countries, as would be maybe in India. This is also a growing problem as well, the limited social support. Again, I'm more than happy if people have any questions in between, but I'm more than happy to stay at the end of it to answer some of the questions as well. I thought I would just start with one case scenario which made me think hard and fast as to how I was looking at addiction and treatment of substance use disorder, and changed my direction significantly. This is about a 68-year-old single woman. She was living in the basement in Vancouver West Side neighborhood. Like Vancouver, cost of living is quite high in Vancouver. So many people who cannot afford to buy a house would be living in the basement part of a house. And the homeowner who rented this suite to her was worried that she was not paying the rent. Someone contacted our addiction counselors, and the addiction counselor went and saw the patient, and she was drinking excessively, and she allegedly lost her job as a secretary in a law firm about 6 months ago. Again, the addiction counselor came to me and asked for a home visit. I was doing a lot of home visits at the time. I was trying to do the home visit. You cannot get into the house. It was such a bad state. Like, she hasn't cleaned the house for a good 3 years. Not many of us probably see this kind of situations. She had an African parrot, and it has pooped all over. And then she had a lot of pokings in because of the parrot not being fed properly. And you'd be surprised, the milk in her fridge was about 2 years old. So again, this is a kind of an extreme situation, but it's not uncommon. And why I'm raising this is she was using alcohol. What we would consider as a severe alcohol use disorder, but that was not the problem alone. So she started showing cognitive impairment because of alcohol use, and she was fired from the job. She didn't get her pension. It took us about 2 years of advocacy to get her into a better place than where she was living, and also to get her severance package and all those things. So this case, this patient made me think about how we were treating addiction, and later on it evolved to a team where I now have a small team which provides alcohol-related brain damage service, which is, again, there are quite a few sites in United Kingdom. They have this kind of a program where we try to rehabilitate people who have cognitive impairment and severe addiction, and then get them back to the society or more supported living. So the approach and the outcome might be slightly different in Indian context, but the substance use and the brain damage is not greatly different. Okay, so again, with the help of Dr. Rajkumar sir, we got this the prevalence studies as to how much prevalence is it alcohol use in elderly, like 60 plus. The data, the latest one which been added is 2015, where 28% of men and about 0.9% of women aged 60 and over use alcohol. Again, with a large country like India, where there is such a cultural and demographic variation, it is very unlikely to be true in all the sites, right? If you measure it in Assam or Chandigarh or urban Mumbai, might be different compared to where you measure in southern Tamil Nadu. So you cannot have a reliable measure to look at what's the magnitude of the problem in India. Again, just to touch upon the DSM diagnosis with symptom criteria, what comes as a long list of symptoms in DSM-5 diagnosis. It categorizes mild as 2 to 3 symptoms, moderate as 4 to 5, and severe as 6 or more. So in a way that DSM-5 got rid of the previous measurements of harmful use of alcohol and other things. By and large, what we are talking about today is mostly moderate and moderate to severe, because more often than not, people with milder symptoms don't necessarily come to psychiatric services or addiction rehab programs. They often end up either seeing their general practitioner or general internist before they can reach you. Again, this is basically a list of substance-induced disorders which are highlighted in DSM-5. Just a little bit on age-related issues and alcohol. To start with the age-related issues, aging is an era of multiple losses, right? So you stop working, you lose loved ones, you maybe stop driving, and sudden retirement or change in the circumstances would or potentially can give rise to financial problems. You might be downsizing housing, and also to an extent, because of the loss, there is a level of social isolation and different complexities in medical issues and mobility and cognitive impairment. So aging comes with its own medical and psychosocial factors. When it comes to aging and alcohol, let us say somebody was drinking 2 shots of whiskey a day at the age of 40 is different to the same person drinking 2 shots of whiskey a day at the age of 65, mainly because of the physiological changes, decreased total body water, reduction in liver clearance, and increased sensitivity and decreased tolerance. So the biggest problem with diagnosing alcohol use disorder or any other substance use disorder in an aging population, like somebody who's 60 and above, the usual DSM-5 criteria, it doesn't necessarily go well for that population. So, and you can have more medical and psychiatric and cognitive issues with lesser forms of addiction as you age. Again, notoriously, people who are in their 5th to 6th decade might be having a number of medical issues and number of medications, and the interactions with these medications need to be taken into account as well. So you don't necessarily end up treating substance use as a single illness. Just a little bit on at-risk or heavy drinking. Based on country to country, this seems to change, but as a general rule, in more than 4 drinks on any one day, or more than 14 drinks per week in men, and more than 3 drinks on any one day, and more than 7 per week in women is considered as a at-risk heavy drinking. That means they are progressing towards moderate to severe substance use disorder. Again, there is a Canadian Association of Mental Health guideline for low risk drinking. This is a more Canadian version. If you look at US or UK, there might be a different version of that. Before going into the actual neuronal damage and brain disorder, seeing addiction as a brain disorder, the one thing which I wanted to highlight is the approach of short, or the utility value of short behavioral intervention for substance use disorders. Mainly when people are at the milder degree of substance use disorder, this might work well. Like if they are not coming to see you for predominantly substance use disorder, that means that they are, let us say they are coming to see you for depression or anxiety, and then you take a substance use history, and then you think they are or you can see that they are having mild substance use disorder, maybe this kind of an approach would be helpful, because more often than not, this kind of an approach is usually taken in an emergency department setting. So that's why there is a value to do this in multiple touch points wherever the patient comes into contact. Basically an approach where you do a short behavioral intervention, which doesn't take more than 5 minutes. So this can be carried out in any practice setting. Basically inquiring on, once you have already inquired about the substance use, giving them feedback about personal risk and impairment, personal responsibility for change, clear advice for change, and menu of change options. So this is a simple approach which is often used in structured primary care and emergency department settings. But in the context of Indian practice, you can use this in any setting as long as the substance use disorder is not severe enough. If it is moderate to severe, then you're looking for more active treatment. Okay, moving on to the next item, it is the recommendations for critical issues in the treatment. So again, this is again mild to moderate substance use disorder, where you start talking about treatment goal, a motivation. Most of you who have done training in psychiatry would always assess the motivation for change, which is a key component of substance use disorder treatment. But there is another side to it, where in Western countries, there is a very big push for creating teams to treat people with substance use disorder who are pre-contemplative still. So that's a common terminology they use to treat people who are pre-contemplative, mainly because their ability to motivate towards a psychological change, they have impairment in their cognitive process. So addiction is a moderate to severe addiction is seen as a central domain of the problem, is seen as a impairment in executive decision-making skill. So that's why we are putting a lot of money in people who utilize healthcare quite a lot, people who would be considered as pre-contemplative, but still they would need more assertive help, like how you would do assertive community treatment for people with schizophrenia and schizoaffective disorder type of folks. Okay, so we will move on to the next set of approach, which is basically the central domain of what I'm trying to talk about in terms of alcohol and brain damage. There are lots of terminologies that have been used. Alcohol-related brain damage is currently the common umbrella term to include most of the central nervous system disorder that happens directly in relation to long-term use of alcohol. There used to be a primary alcoholic dementia. If you look at third edition of Organic Psychiatry written by Leishman, and previous documentation in literature talks about primary alcoholic dementia. There is not a lot of this term being used in the literature at this point in time. Obviously, we know Wernicke's and Korsakoff syndrome. In Australian context, they use a lot of alcohol-related brain injury. They equate it to acquired brain injury and do housing models specifically for that. That's a kind of an approach that suits their health system in Australia. We all heard about alcohol-related dementia being a loosely used term, and alcohol-related amnestic syndromes as well. So there are many terms that's been used in this area. What I'm trying to do is bring along this alcohol-related brain damage as an umbrella term, which mostly originated from Europe, mainly in UK, about alcohol-related dementia, Korsakoff syndrome, Wernicke's encephalopathy, and what would be termed as alcohol-related brain injury and alcohol-related amnestic syndromes as well. If you want to have a definition, basically it refers to the effects of changes to the structure and function of the brain resulting from long-term alcohol consumption. So it could be structure and function, or it could be structure or function, mainly because long before you start seeing structural damage, unless you do a PET scan. There are lots of functional changes that happens, more so to start with at the cellular level, and then at a functional circuitry level, and then you start seeing the structural damages in the brain. So CT scan of head is more often than not unhelpful in the earlier stages. But if you think of alcohol use disorder as a neuropsychiatric, neurocognitive disorder in its severe form, then you will start you won't bother about too much about neuroimaging. Again, it also encompasses toxic effects of alcohol on brain cells due to direct neurotoxicity of alcohol, vitamin and nutritional deficiencies. More often than not, they have head injury, and they also chronic alcohol use disorder also causes disturbances in the blood-brain barrier, blood supply to the brain, as well as excitotoxic damage. So every episode of complicated withdrawal, it's important to manage it very critically. If somebody has had a delirium tremens in the past, if somebody has had an alcohol withdrawal seizure, you don't want them to go through that again anytime whenever they come back for withdrawal, because we all know that they relapse, they get better, they relapse, they could go for 4 or 5 cycles, and then they might end up having a significant medical problem, a stroke or a head injury, or end organ damage like a liver failure and things like that. So the reason why I'm trying to say that is every episode of significant withdrawal period itself is a problem. But if it is a complicated withdrawal, you are increasing the risk of cellular damage and eventual cognitive impairment. Again, it is very much, these are all probably in the textbook itself, but what I'm trying to say is that alcohol-related brain injury, if you look at the central domain, it could be an amnesic syndrome, but more often than not, it is a dysexecutive syndrome as well. Again, I am going to skip the Wernicke-Korsakoff. It's more of a theoretical interest at this point in time. Again, the magnitude of problem, it is more of a Western literature, but it's still valid. I mean, not many times dementia is measured under the age of 65. So one of the studies Harvey et al. Measured, it was considered as 12.5% of all the dementias under 65. If you consider the same study of Harvey suggested the prevalence of younger people with dementia, like dementia under the age of 65, varies between 60 to 80 per 100,000 people. This will be 12.5%. But there are literatures in between 2060 and 2020 where they are suggesting that epidemiological data itself is under representation. So they are suggesting that the number of people with the dementia, let us say if you change the term, number of people with a cognitive disorder under the age of 65 is probably goes very much beyond 100 per 100,000. Again, if you include acquired brain injury, like a traumatic brain injury related cognitive impairment and substance use related cognitive impairment, it probably goes well beyond that. So there is no realistic data, but that the prevalence is increasing. Again, medical complications, again, Wernicke-Korsakoff. So this was the hard neurological disorders and liver disorders seen in young and old in terms of percentage of people presenting with alcohol use disorder, right? If you see, you don't see much of Korsakoff in younger people, whereas you would see probably 10% in older people presenting with alcohol disorder. The same thing with Wernicke's dementia, as well as if you look at head injury is comparable, whereas cerebellar ataxia and peripheral neuropathy is more as people age when they, in their alcohol use career. Again, alcoholic dementia per se It's a little bit of a debatable entity. Still, it is being used. Still, it's being considered. But more often than not, there is more than one factor involved in alcoholic dementia. Yeah, this talks about a little bit about how actually the brain, what are the hypotheses as well as some biochemical evidence for brain damage in aging population with alcohol. Again, I was talking about direct toxicity to the neuronal membranes. We all know thiamine deficiencies and excessive glutamate and inhibitory influence of NMDA receptor leading to excess calcium influx. So there are a number of factors involved in how the cellular damage is mediated in chronic alcohol use. We talked about how it causes the damage. Now I'm slightly shifting my focus towards what are the common denominators that determine addictive behavior. So I did talk about the central characteristic of almost all addictive behaviors is impaired decision making. And the key neural substrates in that is striatum, prefrontal cortex. You all would have read about the prefrontal subcortical circuit. So even though we all know, I mean, that's not necessarily a rocket science, but of late, in the last 10 years, they are talking about the role of insular cortex as a key neural substrate in keeping the addiction as an ongoing problem. Basically, the addictive disorder is an imbalance in the activity of the neural system, and insula could play a very key anatomical targeted intervention for addiction. This is, I mean, I'm trying to get a lot of evidence and trying to make it, I'm trying to a little bit oversimplify this, but for understanding it is okay. If you look at the systems I'm talking about, what are the neural substrates? It's not only alcohol. Almost all the substances have a substance use disorder, all addiction system. We have impulsive system, we have a reflective system, and the neural system that intensify the motivation and weaker control of behavior. So there are three important key elements in this. Again, quite often for the last 20 years, we have been talking about impulsive system repeatedly, where we talk about emotional memories with amygdala, striatal cortex, ventral tegmental area, and dopamine system. We talk about basal forebrain region, nucleus accumbens, and we all talk about classical and instrumental conditioning. It is fast, poorly deliberated responses in response to cues. So if you are thinking about cues related relapse, like a person who is in remission walks through a street where there is a wine shop and somebody calls him, and the smell and substance use related other activities are the cues which makes him relapse. So it causes increasing mesolimbic activity by drugs of abuse and reinforces repetitive behaviors. So this is an impulsive system. So we gave a lot of importance to this impulsive system. And then there is something called repeated reward experiences, what is called as an incentive sensitization. Addiction related objects are wanted than they are liked. Like the impulsive system drives and you start liking something, and then it gets through a number of repeated cycles and you give a lot of salience to that incentive, and then it becomes a want. If you think about the concept of narrowing of repertoire, this is something like that. So you use multiple types of alcohol, you have become so moderate to severely addicted to alcohol, then you have a particular type of a ritual and you consume, let us say, whiskey alone and in a specific pattern. So again, impulsive system drives the approach behavior. The other system which is given a lot of importance in the last 10 years is the reflective system, which is basically anterior cingulate cortex, medial orbitofrontal cortex, ventrolateral prefrontal cortex, related to the memory, knowledge, cognition, choosing the long-term outcomes. These are very necessary. As you all know, the base for prefrontal cortex keeps everything under good inhibitory control, and it inhibits the incurrent and disadvantageous things. Obviously, we measure it through frontal assessment battery, go, no go tasks, and all those things, and error detection and conflict monitoring. So when this system gets damaged, that leads on to worse outcomes of addiction. So bottom line, I'm talking about various aspects of executive functions, preoccupation, low response inhibition, low behavioral flexibility. Low decrease in mental flexibility is a very pathognomonic cognitive symptom of prefrontal cortex impairment, and decreased attention and behavior towards future goals. So the reflective system, when it gets damaged, you lose the control over addictive behavior, you lose the self-control, poor response inhibition, and you give a lot of importance to short-term rewards. So again, if over the years, the central domain of cognitive difficulties or issues have moved from just looking at the impulsive system towards the reflective system. The third component, which mainly literature talks a lot about and comes up with some evidence, but where we don't have a lot of treatment or psychosocial intervention, is insular cortex. So the insular cortex integrates the impulsive system, the ventral tegmental area and nucleus accumbens system, and the reward-based system, and it coordinates the processing of sensory and motor experiences. So what happens in people with severe addiction, there's a hyperactivation of insula and then increased craving and urge. Till DSM-4-TR, I don't think craving was a central criteria for addiction, whereas nowadays, the craving is one of the important components because we use a lot of anti-craving medications. So the craving and urge leading to increased risk of relapse. So they give an example of insular stroke wiping out all the urge to smoke nicotine. So again, just to reiterate, there is an impulsive system, there is a reflective system, and then the insular cortex. So these are the three main substrates and functional damages which makes the addiction as severe. And I would probably I can honestly say that if you are a psychiatrist and practicing psychiatry, very, very likely that you will be seeing a lot of severe addiction, irrespective of whether you are practicing in government setting or in your private setting. And treating severe addiction just by detoxing and getting rid of them is probably not going to do any good for them. Again, these are some of the neuroimaging findings I added. Again, we talked about, there is a lot of literature in teaching. It's been going on for 30 years about the importance of mammillary body, microhemorrhages, and then the most importantly, if you can do a high resolution MRI, like a 3 Tesla MRI is available in metropolitan cities and probably outside of metropolitan cities as well. Orbitofrontal cortex and frontal atrophy can be determined with accuracy. Global cortical atrophy doesn't tell you anything specifically, but it does tell that brain is shrinking and neuronal loss. Vascular ischemic change, we never gave a lot of importance to it a couple of decades ago, but the location of the ischemic change, the location of a strategic infarct, like let us say bilateral thalamus infarct, like basal ganglia infarct, are all strategic where fibers crowd as well. So then significant atrophy of the superior frontal cortex, cerebellum, hypothalamus. Probably these are going to be permanent and you're not going to change that, as well as reduction in gray and white matter volume. So the most important thing, there are a number of studies which says that hippocampus gets atrophied in chronic alcohol use disorder, in severe cannabis use disorder, and in if stimulant use is common, where I live, crystal methamphetamine and cocaine is rampant. Chronic cocaine and crystal methamphetamine use gives rise to movement disorders, which you will find it difficult to differentiate between Huntington's chorea and cocaine-induced dyskinetic syndrome. It causes permanent neuronal damage. Cocaine and crystal methamphetamine use causes what we would be calling them as drug-induced psychosis. Eventually, it makes symptoms as severe as schizophrenia and not respond to antipsychotics, and they eventually become psychotic throughout the rest of their life. So almost all these substances have a significant influence on the brain. Again, these are this slide deck I used to use with an MRI image of hippocampus, which I've taken it out for this presentation because there were too many slides. But if you look at it, how learning gets affected, like they did Ray auditory verbal learning test. You can look at this. The blue ones are controls. Then there are heavy social drinkers. It goes down. People who self-refer, and then alcoholics without neurological disease and alcoholics with neurological disease. So it steadily goes down. Obviously, if you have learning problem, you are going to have memory problem, and you will also very likely have executive dysfunction as well. Again, this is mainly, so I talked about functional circuitry changes. I talked about how the damage happens, and these slides talk about neuropathological changes as well. So I think it's self-explanatory, so I would skip it a little bit more. The presentation, they may present with short-term memory problems, but profoundly they will have learning impairment, like new learning ability, difficulty in learning new skills, like they may not be able to use a new phone, they might struggle to use a remote control, all those kind of stuff. And there is a profound lack of insight. We talk a lot about denial in substance use disorder. In this setting where we talk about a clear lack of insight because of what I mentioned about cognitive impairment. Again, apathy and repetitive behaviors. Apathy is a significant specific neuropsychiatric syndrome. We don't give a lot of importance to apathy. Many times we think apathy is a component of depression or something like that. Apathy as a standalone disorder is a significant problem as a result of number of neuropsychiatric disorders. Like if you take Parkinson's disease, Huntington's disease, acquired brain injury, dementia, right? Apathy is a significant marker for conversion from mild cognitive impairment to dementia. Apathy, somebody with a brain injury and apathy will have a moderately poor prognosis for rehabilitation. A substance use disorder patient with significant apathy also will have significant impact in recovery. Why? Because there are three critical components of apathy. One is goal-directed behaviors, like the umph and the drive. Goal-directed emotions, seeking pleasure. When I say pleasure, it's more of a socializing and things like that. And the goal-directed impulses, like if you feel hungry, you need to eat. If you feel you need to have a shower, so need to change, need to keep yourself clean. That's a basic domain of self-care activities. So these three domains of goal-directed behaviors are lost, you have a severe apathy, and severe apathy is often difficult to treat. Many medications have been tried, like Zyban, the bupropion, bromocriptine, other dopaminergic agents. But apathy itself has roots in number of type of disorders. Apathy is very common in basal ganglia disorder. Apathy is very common in disorders of executive dysfunction. So you need to choose the type of a medication based on what type of a cognitive disorder or brain damage disorder we are talking about. Methylphenidate is being used for apathy in Alzheimer's disease. Methylphenidate has been used also in apathy in acquired brain injury. So like that, apathy is a central theme. Often they can come disheveled to the clinic. You might think it is all related to drinking too much and falling in places and things like that. If you dig a little bit deeper, whether they are very much like that even when they are not actively drinking, let us say if they had 3-4 days of abstinence, and even during that time they don't actively take part in any self-care activities, they don't eat unless they are given food, then you are definitely talking about apathy. I did talk about executive dysfunction. Some other skills which are kind of preserved in alcohol-related brain damage, at least in the early stages, is well-learned social skills and manners and pleasantries might be preserved. Immediate memory, basic concentration might be preserved. It doesn't affect language functions that much. So when we talk about language in the neurocognitive disorder area, you talk about reading, writing, comprehension, expressive language, repetition, pure word knowledge, and the semantics and all those things. They may not have significant affliction in language areas. Obviously, long-term memory remains good, and well-learned skills could still be good in the mild stages of alcohol-related brain damage. Again, apathy, poor motivation, neglect, and disinhibition and impulsivity, depending upon how much of prefrontal cortex is affected. Behavior problems could include angry outbursts, moodiness, confusion, withdrawal, lack of motivation, and sometimes I've seen sexually inappropriate behaviors as well, which is a sign of a more significant frontal lobe dysfunctions. I like this. I took it out of a journal article. It's a very, very nice flow chart which talks about how people end up with permanent brain damage when they are using alcohol, like excessive drinking associated with some low income, social drift, failed prophylaxis in the community, or there is no prophylaxis in the community. They straight away end up having Korsakoff syndrome or alcohol-related brain damage. Some people do get hospitalized, recurrently hospitalized, treated for Wernicke's, adequately treated, then they have to go for rehabilitation. Inadequately treated, still they will come back with the brain damage. Not diagnosed and not treated, slam dunk, they will have brain damage and cognitive problems. This hasn't changed in the last 10 years. So I've been using this same slide for 10 years. It still continues to be true. Again, this is more in terms of a Western setting I'm talking about. You can still use MoCA, Montreal Cognitive Assessment Test, is one of the commonest tests here used here. Addenbrook's cognitive examination is one of the common thing which we used in UK. But having said that, frontal assessment battery can be used. It doesn't take much. Frontal behavioral inventory, I don't know if there is a translated version of that. Obviously, neuropsychiatric inventory can be used as well. The Montreal Cognitive Assessment, I think it has got multiple language versions. Worst comes, you can use MMSE, clock drawing, and incorporate clock drawing, verbal fluency, and trail making B test. Why? Because clock drawing, verbal fluency test, and trails test are probably the most sensitive to go along with MMSE. But if there is a translated version of MoCA, it is useful as well, as long as it's validated. Again, if you have an opportunity to get a neuropsychological assessment, there is an array of neuropsychological tests that can be used. They can also do a structured assessment of executive functions. Again, the approach to diagnosis. When I say the approach to diagnosis, anybody who is 50 and above with severe alcohol use disorder, with a history of significant nutritional deficiency, folate deficiency, B12 deficiency, delirium tremens, and seizure, think about alcohol-related brain damage. It may not be to the level of dementia, but if you don't think about alcohol-related brain damage, you will probably detox them, maybe treat them for a short period of time. It's not going to do them much good. They will have relapse. Probably your success rate will be 20 to 30% or not even that to keep them abstinence. But try to touch upon a few other things, like are there other symptoms of end organ damage, any liver, pancreas, variceal bleeding. I mean, CT scans are available in almost every town, but doing MRI does help quite a bit. And the reporting of MRI will be as good as what you ask. If you don't ask about, give us a clear account of ischemic change. There are softwares which radiologists would use to report. What doesn't help is there is moderate ischemic change. That doesn't help. You need to ask where those ischemic changes are. You need to ask about specific atrophy in the medial temporal lobe, frontal lobe, all those kind of stuff. So when you are able to scan, MRI is preferred. If you see one type of an end organ damage, you need to be really alert that could there be a brain damage as well. When there are symptoms like history of head injury, loss of consciousness, more than 5 minutes, more than 30 minutes is significant. 5 to 30 minutes is also significant. Starting of incontinence, and always keep a watch out on delirium tremens and seizure. You want to prevent another seizure from happening when the patient comes back again with another episode of intoxication and withdrawal. So the most important bottom line is you need to establish the substance use disorder. You need to establish a cognitive impairment when not under the influence of alcohol. What would not be considered as a baseline is somebody who has been drinking daily for many years. You detox them. 2 weeks later, you measure the cognitive functions. That will not be their baseline, because alcohol, as I was talking about, it causes some sustained damage to the brain and cognitive function. So you need to give them, at least theoretically, it is 90 days of abstinence. At the least 30 days of abstinence would give us a better picture, because many of these folks improve quite significantly. So the data from Western countries where they do alcohol-related brain damage surveys, 50% of them improve very significantly in their cognition. 25% of them shows a reasonably, like, some improvement, and 25% of them don't improve. Probably those people do fall under typical dementia category. Always aim for abstinence in this age group and with this level of damage, because there is no role for controlled drinking. And there are Western countries which do managed alcohol program and things like that. It's not going to work for this population specifically. Again, before I keep moving, any questions, comments? Okay, so yeah, feel free to share any thoughts. I would keep moving, because just to keep my talk on time. Again, I did talk about what to ask in neuroimaging. So just sending an MRI head is not going to work out. So you would need to ask specific things. That's what I have listed in this. Again, examination, you have to rely on your mental status examination and cognitive testing. Collateral information, you can make a checklist and ask families to give you that collateral information. A little bit of a neurological examination is must. If you can do fundoscopy, good, but at least check peripheral neuropathy, focal neurological deficits, gait, extraocular movements, nystagmus, small muscle atrophy, a quick motor check. So That's very important, and get the history about daily living, day-to-day living skills. Usually, it's very difficult to ascertain this diagnosis with one appointment itself. So you would probably need to do a serial cognitive assessment. If they are abstinent, you can do an interval scan, which will give you any structural changes in the brain. Okay, so if I have to talk about management, this is the most important thing. If you don't screen and don't think about it, you are not going to be treating that. You can identify through risk factors, which I have highlighted and probably repeated myself twice there. Optimal management of acute situations, nutritional supplementation, prevention of DT and seizures. You need to be able to use whatever your local protocol is. I mean, some places use, even in Canada, they have multiple sites which use chloridized epoxide, multiple sites which use Ativan, and there are a number of other sites which have used some anti-seizure medication as well. And in one of the large tertiary hospital here, along with chloridized epoxide, they also use valproic acid. They have their own theory as to how it is helpful. In community detox settings, there are a number of sites here which use gabapentin and acamprosate along with benzos. And once the immediate detox is done, the acamprosate and gabapentin is continued for at least 6 months. Many times, I personally continue the Camprol for at least 2 years. I mean, there are only small number of studies, but in those studies, Camprol did have a potential to minimize the damage which I was talking about. When there is a complicated withdrawal happens, the glutamate mediated damage to the brain can be minimized. And there are 1 or 2 studies which talk about prevention of alcohol related withdrawal seizures when acamprosate is started in full dose when the patient is actively drinking itself. So if you start 666 milligrams 3 times a day and the patient is actively drinking and then taking them into detox, having a whatever protocol you have in terms of using diazepam or chloridazine epoxide and still keeping acamprosate tend to prevent seizure and improves or prevents further brain damage. Again, medical stabilization or what they call it as a medical stabilization and managing the early encephalopathy kind of a symptom. Then there is a period of fast improvement. The stage 3, 4, and 5 is what many of our community-based alcohol-related brain damage program does, where they work with them in multiple settings, improving their social functioning, improving their social cognition, teaching them some error-free learning and some adaptations to improve independence and minimize the further cognitive damage. That's the kind of a program which we are running in the community. Again, I did talk about, so if the cognitive impairment is not improving but not deteriorating, it's important to create weekly routines. And if they have to do a minimal set of repetitive activities, then it make them more independent. If the activities clearly mention about getting up, having a cup of coffee, having a shower, doing some prayers, maybe doing some a little bit of a work, structured work at home, and then stay at home and watch TV. So if there are a limited number of activities that they can practice that over and over, and it creates independence. This can be trialed even in a structured rehab setting. If you run a alcohol rehab program, you can do that. Like narrowing the number of activities and minimizing the active group participation and creating a weekly routine which can be taken to an independent living setting as well would make sure that they have more autonomy and feel good at the at the end of the rehab. Again, to add something in Indian context, enhancing rehab with longer stay is conducive, mainly because shorter detox doesn't contribute much to anybody. Again, memory and learning, there are lots of focused rehearsal aspects of things that can be used, either spiritual or prayer techniques, which can be repeated. Again, with limited repertoire of activities would help quite a bit, and repetitive smaller steps towards reading, learning, and recall. In some situations, you would probably need to start using whiteboards and visual learning more than reading. As well as social cognition groups, it does help with minimizing disinhibition and making their communication more appropriate. So these are all activities which can be done in any setting. It doesn't need to happen only in Western countries. And also this can be done if the patient has a good social support by the family members too. I just wanted to give a list of medication options like disulfiram, quite often used but we seldom use disulfiram because of other medical, legal, and other issues. We use naltrexone and acamprosate. They are sold as an anti-craving medication here, so we use quite a bit. Again, these two have different mechanism of action, so sometimes we would use both. I have a lot of trust in acamprosate, even when somebody is actively drinking, because it reduced the number of drinks somebody takes. It did reduce the withdrawal related seizures, and it does have benefits towards preventing excitotoxic damage. In somebody who has had established cognitive impairment, I would even use donepezil and memantine. Memantine acts on the NMDA receptors. We did talk about NMDA receptor mediated damage. Gabapentin is quite often used here for a period of 6 months or maybe more. Again, the concept is it is used as a relapse prevention strategy. What we also forget is that every chronic disease like alcohol use disorder or any form of addiction causes a significant inflammatory damage to the brain. This is just being studied, but the medications which I have mentioned, coenzyme Q10, omega-3 and N-acetylcysteine, omega-3 and coenzyme Q10 are over the counter. It's available everywhere, available in India as well. It prevents or minimizes the antioxidant mediated injury and does help in a smaller subset where there will be inflammatory causes as one of the, in a small subset of population, that will be one of the main causes of brain damage. Having said that, there are articles published in Nature Neuroscience within the last year, which talks about how much inflammation influences multiple systems in our body. Diabetes mellitus, sleep apnea, you sleep less, you cause more inflammatory damage. Obesity causes more inflammatory damage. So many aspects, inflammation is one of the mediators of damage that also happens in substance use disorder. And coenzyme Q10 at the dose of 100 to 300 milligrams per day, like 100 milligrams 3 times a day, 100 milligrams two times a day. It's an over-the-counter medication. You don't even need prescriptions for that. So that also useful. I mean, we have used high-dose coenzyme Q10 in Huntington's disease in the earlier stages of illness with some benefit because of its antioxidant effect. Okay. Just in the interest of time, I would move. Again, high-risk individuals, always think of when somebody has more than 10 years, very severe binges, recurrent withdrawal needing hospital admissions, and more than 3 hospital admissions per year with a recurrent history of DT, withdrawal seizures, and confusion head trauma, very likely that they are going to have alcohol-related brain damage. The very Western problem is homelessness. Again, unemployment and self-neglect related to alcohol use disorder can happen in any society. So all those things are high-risk individuals if you want to use a risk-based approach in identifying these people. This I used for a while as to measure how much my patients are drinking, even if they are not coming to see me for alcohol use issues. I always use the period of loss of consciousness as an important indicator. My approach to that has changed a little bit because 30 minutes of loss of consciousness or longer becomes a severe injury. So even 5 minutes to 30 minutes is also important. Somebody gives you a 10 minutes history of a 10 minutes of loss of consciousness is also very important. And then there is history of stroke, suicide attempt, which can cause anoxic brain damage, and marked change in the cognitive functioning, resulting in not because of any other disorder. Okay, there are some couple of questions in the chat. I'm happy to address that. I wouldn't take more than 15 minutes for cannabis, and then I'll come back to answer the question. So again, because I wanted to focus a lot on alcohol use disorder and brain damage, I've shortened the overall cannabis cognition brain damage, but the next 20 years of problem is going to be not only alcohol. Currently, our major problem is cannabis. The most difficult problems to treat are cocaine and crystal methamphetamine related brain damage. So that's a very significant challenge because there is no treatment for stimulant use disorder, which is FDA approved. Obviously, there are lots of phytocannabinoids. We predominantly in the scientific literature, or at least in substance use disorder literature, we talk about tetrahydrocannabinol and cannabidiol. The only interesting difference is that cannabidiol CBD is not it does not provide the same activation and high as THC. At the same time, the reason why I'm talking about CBD is as I go along, I'll tell you about a literature which could partly explain why it is important to understand CBD, mainly because out of these components, CBD is more neuroprotective, whereas THC increases the odds of having psychosis, whereas CBD higher dose is being trialed as an antipsychotic for antipsychotic effect. So we have a provincial treatment-resistant psychosis unit. There they have tried CBD as a form of augmenting the antipsychotic. In my treatment setting, in my practice with the Huntington's disease, some of my patients, not a lot, they use off-label CBD oil, and some of them have come back and their need for antidepressants have gone down. And my colleague neurologist who also works with me in the same clinic tells me that some of them had a small improvement in motor scores in Huntington's disease. But there's no evidence to support it. There was only one trial which was done in nabilone. Nabilone is a synthetic product and did not have a lot of benefit when it was trialed in the clinical trial setting. Again, without going into the depth of how THC works and makes this kind of a euphoric and effect basically chemically similar to our endogenous brain chemical, anandamide. Again, cannabis use and mental health. More than 75% of significant people who have cannabis use disorder have dual diagnosis with another mental illness. Around 50% of them have a strong personality disorder, common things being antisocial personality. Bipolar disorder, psychosis, agoraphobia are also common denominators in cannabis use. Cannabis is a gateway drug where teenagers start using cannabis. Teenagers who start using cannabis at an earlier age tend to go on to use lots of other substances. So that's why they keep calling that as a gateway drug. Again, people who have cannabis use and a mental illness most of the time start using cannabis at an earlier age. And then there was a Dunedin birth cohort study where people who used cannabis later on turned out to be psychotic between their age 11 and 21. So in that way, cannabis has a lot of evidence to and are associated with psychosis. This is a kind of an interesting map which I searched for this presentation to put it in here, where if you look at the world map, the countries which are on blue are having a kind of a mixed state in terms of cannabis. So they might approve medical cannabis, they don't approve recreational cannabis. Those are the countries. And the countries which are in the maroon red countries are where cannabis use is strictly illegal. If you look at it, India, much of Middle Eastern countries, much of Russia, China, all those areas fall under that category. Mixed status, if you look at it, UK, Australia, and much part of America falls under that, and even South America. The green countries are where cannabis use is legalized. So the biggest green you see in the map is where the country I come from. So recreational cannabis use has been legalized in Canada for the last 3 years or something like that. And then there are spots of green countries here and there, if you can see, Uruguay, Switzerland, and a few other countries where it has been legalized. I was searching for Indian literature. Probably there are other good literature as well. I picked up this one mainly because it talked about, as earlier in this talk, I was talking about we cannot rely on one site alone. So look at Chandigarh, Punjab, Karnataka, Uttar Pradesh, and Gujarat as to what was the prevalence of cannabis according to the study. This study talked quite a lot about higher prevalence in Chandigarh, Punjab, and slightly lower in Karnataka. Probably it is not necessarily a representative sample, but still it is something valid to see. Again, chronic cannabis use decreases the gray matter volume in medial temporal cortex. Temporal pole, parahypophyseal gyrus, left insula, and orbitofrontal cortex has changes. Heavy cannabis consumption, independent of age of first use or recreational consumption, started during the adolescent age, causes significant brain damage. So this is the voxel-based morphometry result of how much cannabis, the red-colored ones are heavy use, more heavy use than occasional use, and the blue-colored ones are areas where there is atrophy in occasional use more than heavy use. Again, this one, we go around and talk about risk of cannabis and psychosis. Again, obviously, in somebody with a family history of psychosis, using cannabis increases psychosis. Early use of cannabis gives rise to a number of other substance use disorder. But cognitive impairment, when in a developing brain, when they start using cannabis before the age of 18, and then if they start continue to use it for a longer time, there is an actual reduction in IQ. Basically, dementia itself is a reduction in overall IQ, but in this context, we talk mainly about adult population, right? So there is a significant reduction in IQ with chronic cannabis use. Some studies has shown that. Influence in the brain development, some studies have shown that. Whereas cognitive impairment, especially the learning deficits with chronic cannabis use, is still equivocal. It is not necessarily proven beyond doubt. The reason being, when they studied population of schizophrenia who were using cannabis, the cohort of population who had schizophrenia and cannabis use performed better in number of aspects of cognitive functions than those who were not using cannabis in the background of schizophrenia. The reason why I wanted you to look at the CBD, which there is a pharmacy grade CBD in America. It's approved for treatment of Lennox-Gastaut syndrome and another form of childhood epilepsy. So there is a recent systematic review of use of CBD in chronic pain. So there are a number of areas of evolving evidence for CBD, but pharmacy grade CBD is quite expensive. I'm not sure if it's available in India. There is none pharmacy grade CBD is available in Canada, but off the market CBD oils are available. So one explanation as to why people with schizophrenia did better in some aspects of cognitive functions when they were using cannabis was probably the CBD content of cannabis was helping them. So I would like to finish with this, and I would really like you thanks a lot for this opportunity to present some of my area of interest and literature. There are a couple of questions in the chat. I'm more than happy to take that. What is the chance of recovery for alcohol-related brain injury or cognitive impairment? The chances of recovery, as I was suggesting, is based, let us say somebody with alcohol use disorder comes with cognitive impairment and there is a very big or significant cerebrovascular disease related change. Their chance of full recovery is minimal. Whereas somebody who comes with predominantly severe alcohol use disorder and not a lot of structural damage to the brain, the chances of recovery is good. But as the literature says that it takes 2 years, up to 2 years to show improvement. 75% of the population who are in the program, it is not one program I'm talking about, there are multiple programs across Europe, and there are a couple of programs in Australia as well. Their chances of recovery was good, good enough to live independent life. So that's what there are individual factors which make things difficult to have a standard prognostic conversation without seeing the other systemic illness and other things as well in the family, in the patient. Efficacy of pregabalin versus gabapentin, which is better? Again, pregabalin is obviously a better medication choice, but I'm not sure if pregabalin found a place in American Society of Addiction Medicine alcohol use disorder guidelines. Maybe it has, but it's not commonly used in Canadian context. Gabapentin is widely used, and there are other things which have been recommended by the American Society of Addiction Medicine that includes topiramate, even though the scale of evidence for topiramate is not that huge, but it came as a recommendation as well. But the primary medications for alcohol use disorder based on the recommendations are still acamprosate, naltrexone, and then gabapentin has some place as well. If there are any other questions, if you want to send it in the chat, I'm more than happy to address that. Otherwise, I would give it back to Dr. Rajkumar, sir.
Ashok, an excellent talk. You've become distinguished, gray in hair and also quite knowledgeable. Actually, we're running short of time, so I have to thank you and close with this and go to the next speaker. But I will contact you later. Okay.
Thank you. Thanks a lot, sir. Thank you.
You're very welcome. Thank you. Bye-bye.
All right. Bye.
The next speaker is Dr. Hari Subramanian. Hari was my colleague in Leicester. It's a beautiful small town with a lot of Indian population. Hari's been there for, I think, at least about 20 years to my knowledge. He's been working on this particular niche area called capacity assessment in elders, which is an important topic as far as psychiatrists are concerned, because in old days, sometimes the decision-making capacity is questioned, and that can lead to a lot of issues. So I have requested Hari to give us a talk on this topic. And without further ado, I will ask Hari to take over. Thank you. Please start, Hari.
Hello. Hello, can you hear me?
Yes, sir, you're audible.
Oh, okay, thank you. And can is the slides seen?
Yes, sir, we can see your slides.
Oh, thank you. Thank you very much. Yeah, thank you, Professor Rajkumar. I think we've been colleagues, and I'm really honored and delighted to be here. I think I must say that I quite learned a lot from the previous speaker too. I mean, it helps to refresh some of the old neuroanatomy, neurophysiology. That was quite an interesting topic. But I think there's quite a lot of similarities between some of those, what he said and what I'm going to say. And essentially, it's this, that despite all the developments, there remain a lot of areas that perhaps still need a lot of attention, really. I'm hoping that this topic is going to be slightly different to that. I want it really to be like a discussion, and I wanted to so people to interact as much as we can. So I'll just get on straight into it. The first thing to say is I am really, really pleased that the Indian Psychiatric Society has got a human rights task force, and they did conduct a World Elderly Abuse Awareness Day. And I think some of the, although this is supposedly an elder issue, it's not really. I think it applies to a lot of our patients, whether even younger or older, and some of the central issues are still the same. What I will try and do in this talk is to try and outline some of the practice that I take in the Western world, but obviously that has allowed me to look at some of the gaps that perhaps exist in an Indian context, and I might just outline it for the audience. It's not as if to say that I have the solutions, or indeed you have the solutions, but I think it's a way of raising awareness. And I think the more we are all aware of it, the more we can be cognizant of it, and our practices will develop accordingly. So yeah, I think as I said before, I do a little work for what is called as a Court of Protection and the Office of Public Guardian in the UK, and which is largely to do with capacity assessments in people who may not have capacity. I'm trying to see how to, yes, okay. Yeah, so in the Western world, there are quite a few laws that apply in the context in which we practice clinically. The Human Rights Act, I think people will know that. I mean, it's something that came out of some of the atrocities that happened in Europe and has been modified or changed in many ways and incorporated into the laws in several countries. But I think when we say things like "I have my rights," what essentially we're saying is that we have rights which is enshrined into the Human Rights Act. So some of the Human Rights Act will affect the day-to-day practice because they will apply to our patients with mental health problems as much as it applies to other sort of patients too. In the UK, we have a Mental Health Act 1983, which has been modified to 2007, which is probably very similar to some of the mental health acts in the Western world. What I think there is a slight difference is that we have now what is called as a Mental Capacity Act. And I think in the next subsequent slides, I'll try and distinguish between the two acts and why it is that we require two acts. But I think it's unique in the sense that not many areas of the world have got Mental Capacity Act, and I think it's particularly it is more relevant in an Indian setting because I think there doesn't exist a statutory law to that, and I think if we as practitioners are not mindful of some of the compromises that might happen, then we could perhaps not in an intentional way. We could in a very unintentional way contribute to some of the erosion of the rights, and therefore it's important that we are mindful of this. And I think in the recent context, there is something called Deprivation of Liberty Safeguards, DOLS, which is currently being revamped into what is called as a Liberty Protection Safeguards. Now, what essentially this is that although we've got two acts in the Western world, and certainly in the UK, there still seems to be a gap, and patients seem to fall between the two. And here I'm thinking essentially of people with advanced dementia, maybe, who do not have ability to express or articulate their wishes, but at the same time, they're not really refusing, and they're not really asking to go or asking to leave or denying access or to treatment, but it's just that they get treated, but they're not really treated in the mental health act setting because it's not really treatment, it's more about care, but they're not really capacities enough to accept it. So we still, I think the law in this area is still evolving, and we do what is called as a DOLS, which is we are trying to work out a way by making their detention lawful. And of course, for the children, there are other acts, but I'm not going to talk about that. I'm certainly no expert in it. So as clinical practitioners and as psychiatrists, I think the day-to-day sort of our clinical practice gets affected by two main areas. So when we have got to provide treatment for a patient, or when we have got to provide an intervention, then we've got to decide whether we use what is called as a Mental Health Act or what is the Mental Capacity Act. And I think these are two statutory acts. And essentially the word statutory is here very important, which is enshrined in the law. And I think before, as you see, Mental Capacity Act became a statutory law in 2005. Before 2005, what was being done was deemed as being done under common law, or what is called as a best interest or common law. Essentially, for example, if there's a confused, demented lady living at home and she needs to get her shopping done, then the carers will go and use her money and get the shopping for her. But actually, you know, what sort of legal protection do the lady have, or indeed the carers have, because either of them could accuse of the other of misappropriation. So I think it was all being done under common law, but obviously it was felt unsatisfactory, and so therefore it's more codified now into a proper what is called as a Capacity Act. And so we've got that, and I'll talk about that in a minute in terms of the differences. And of course, Mental Health Act people are more familiar with. People who are detained in hospitals, treated against their wishes, injected against their wishes, all that will fall under the Mental Health Act. So I suppose the legal structures in many high income countries, there are two separate legal structures as we talked. And the principal point of difference between the two acts are that the Mental Health Act care, it's a care-based act based on risks. Mental Health Act is a risk-based act. And the Mental Capacity Act is really based upon capacity, whether somebody's got a capacity for a decision or not. And that's the key. And if you look at the statutory legal papers of the Mental Health Act, it really doesn't talk much about capacity. It talks exclusively of risk, as whether they are risk to themselves or risk to others or risk to their own health. But of course, there is interfaces between the two. So as I said, England and Wales, we've got two sort of mental health acts, Mental Health Act and Mental Capacity Act. And of course, any jurisdiction will need to manage the interface between these legal frameworks. So as we said, Mental Health Act is primarily concerned with reduction of risk to self or others, whereas Mental Capacity Act is designed to enable individuals to make their own decisions as far as possible, and actually to ensure that the decisions are made on their behalf and they are in the best interest or they're least restrictive. So let's look at some sort of scenario. As I sort of alluded to before, a 75-year-old lady lives alone. The carers visit her daily, need to get her shopping, need to withdraw money for the shopping. So that's a scenario where before, some 10, 20 years before, I mean, this would be done just as what is called as common law, doctrine of necessity. And well, as you can see, because it's not codified and there is no statutory law, it is prone, or it could be misused by either parties, really. Another scenario: an 80-year-old lady placed in residential care home, and the home and her home needs to be sold. The funds need to be released in order to pay her care home fees. So these are all essential day-to-day tasks that needs doing, and of course they get done. But I think the question is what law or what framework we do in order to do it. And as you can see, these are not really more about treatment, and they are more about principles of what is called as best interest, or what is meaning to be done in their sort of interest, really. And these are sort of scenarios where we need to apply the Mental Capacity Act. So let's look at some other scenarios. So we've got here a situation where, I mean, I'm imagining it, and you as practitioners might be able to tell me much more, but I think I'm going to pause here and invite a couple of thoughts because it is helpful. But in this case, an Indian lady has got mild psychotic illness. She occasionally refuses to take medications, but is well supported and managed by the family at home. What the family do is they mix the liquid medication every night along with the food. So that's one scenario. And a subsequent situation is the same lady now wishes to go shopping, but the family tell her for various reasons, which perhaps include things like social stigma, she's not allowed to go, and that they will do the shopping for her. So, I mean, does it seem familiar? Will somebody give me a few comments? Clinical practitioners, you see this day to day. Sorry, is it? I didn't get that. I take it, was somebody trying to give me a response? Okay, well, I'm not quite sure whether I heard that, but I'll carry on. What I'm essentially trying to emphasize is that these are very familiar clinical scenarios that I think you would be facing on a day-to-day basis. And sometimes we just take it for granted. But what the point I'm trying to make it is we just need to be aware that some of their rights here in such situations or may be compromised. It may be the right thing to do clinically under the situation, but it's important to be aware that perhaps some of the rights here are getting overridden, really. So, I mean, these are sort of things that go towards the framing of the Mental Capacity Act. And essentially, it is now a Capacity Act is enshrined in the statute, and it's basically depends upon what is called as a doctrine of necessity, really, and that we have a requirement to do what is in their best interest, and we have a formal way to test and record their capacity. And I think sometimes it is quite easy, really, that we sometimes just make a decision somebody's capacitous or not capacitous, but we do not necessarily follow through a protocol or follow through a proper way of documenting it. But I think the Act requires us to do that. And of course, the Mental Capacity Act allows decisions about advanced decisions to refuse treatments. And it's also what is called as substituted decisions, wherein really, I think it allows a nominated deputy to do those decisions, and things like lasting powers of attorney. So these are all enshrined in the Capacity Act. So I think going back to the Indian Mental Health Care 2017, I think you practitioners will be more up to speed. But what I gather is that there is not much of capacity which is being mentioned in the Indian Mental Health Care Act. And it's really talking about rights of persons with mental illness. And it talks about things like advanced directives and expectations on the mental health establishments. It talks about admissions of persons with mental illness, decriminalizing suicides, and talks about ECT being done under general anesthesia and muscle relaxants. And it also qualifies the responsibilities that other agencies have, and more about financial punishments if it is violated. But it does not have a separate Mental Capacity Act. And I think it's incorporated within the Mental Health Care Act itself in Chapter 2. But there is no succinct emphasis on the capacity. So I think it's important perhaps to sort of just reflect on the two different variations, and which will then perhaps hopefully outline that some of the decisions that perhaps happen in a clinical setting is uncovered really. It's not covered under the capacity in the Mental Health Care Act, but it's also perhaps not really have got legal framework because there isn't a enshrined Capacity Act or something similar legally to cover those sort of areas. So the Capacity Act is based on presumption of capacity and principle of autonomy. And of course, the Mental Health Act is based upon all sort of risks, really, and prevention of those sorts of risks. The medical treatment is really, in Capacity Act covers physical as well as mental health treatment. So if somebody comes in from a road traffic accident unconscious and you treat them, what you're essentially doing is you're treating them under the Mental Capacity Act. But in treatment of mental, in the Mental Health Act can only be used for treatment of mental disorder. And the Capacity Act clearly expresses that all the decisions must be in the person's best interest, whereas the Mental Health Act does not say that. And there is also the use of power and the use of resistance. So really, the Mental Capacity Act here in the Western world clearly specifies that you can only use limited restraint to protect the person from harm. And if anything more than limited restraint is needed, then alternative framework is needed. Whereas in Mental Health Act, you can hold and use powers for compulsory detention and treatment. So there's new procedures is what we call as DOLS. So a very confused elderly patient who perhaps is trying to leave, we try and put an arm around them and gently guide them back. What we are really doing there is using a statutory power, and that statutory power is enshrined in the Capacity Act, or perhaps in now the new formed, and which perhaps will be modified soon, called the DOLS. So those are the acts which allow us to give her the power to try and redirect them and prevent them from sort of putting themselves really in a very confused state at some sort of risk. And there are safeguards built in with the Capacity Act, which is really about consulting with a family, consulting with the carers, whereas the Mental Health Act really talks it's almost a very military act. It talks about nearest relative, it talks about using second power, second opinion advisory doctors, appeals to tribunals, etc., etc. So again, advanced refusal really can be overridden in terms of Mental Health Act, but you really can't override it in terms of the Capacity Act. In terms of proxy decision makers, attorney or deputy have no authority under the Mental Health Act, whereas attorney or the deputy may make all the welfare decisions or healthcare decisions in the Capacity Act. And of course, there are independent monitoring facilities available for both of these acts. So in the Capacity Act, really, in clinical practice, really, the key is about putting patient at the heart of the decision and assessing whether they've got the capacity and whether they're actually doing what is called as an informed consent, and whether we're sort of acting in their best interests. And there have been several challenges, and I will go through some of those, but I don't want people to get hung up upon the numbers or the details of those acts and so on. It is there, it is easily obtainable. But also I've ensured that you've got a PDF, so you can refer to it at any time. So don't feel you've got to try and remember this. I mean, I've just put it for the sake of completeness. And what I'm trying to emphasize is the principles, really. So the principle of Capacity Act is to assist and support, and it's not really about restrict or control, and that's the difference. And I think what I'm trying to emphasize is sometimes, even in Indian setting, we might be using restrict and control, but sometimes this area of assistance support is perhaps not being considered. And I think it's important to think as clinicians whether there is a slight distinction between the two. And there is a central presumption of capacity. All the practical steps should have been taken. And somebody, if they made an unwise decision, the law does not sort of say that you cannot make an unwise decision only because you're incapable. So the law does allow even unwise decisions, as long as it's done in the right sort of way. And the acts which are done for P here refers to the incapacitated patient. The acts done for P must be done in the best interest, and we've got a duty to look at lesser restrictive options. I won't go into details, but there is clear attempts to define what is capacity, and they talk of what is called as a diagnostic test and what is a functional test. A diagnostic test is whether somebody's got a diagnosis, but just because somebody has got a diagnosis of dementia, it doesn't automatically mean that they are incapacitous, and therefore we have what is called as a functional test. And plenty of times in the courts, it has been proven that even though somebody has got dementia, for that particular decision that they were required to make, they were able to process information, weigh it up, and they had enough sort of abilities to process the information, and therefore they were functionally found to meet the threshold for capacity. So not only they've got to meet a diagnostic test, but also a functional test. And both of them should be met in order for somebody to either be declared having capacity or not having capacity, as the case might be. And there are some challenges in this. So basically, if the disease, I mean, I think the balance of probabilities is the key here. The phrase balance of probabilities, and what it really means is sometimes you make these decisions are questioned in hindsight. So the question will be, on balance of probabilities, do you think that this lady was capacitous in making, I don't know, a decision such as gifting 5 years ago? So I think it's often in hindsight, and that's where it's important to understand what the balance of probabilities mean. And balance of probabilities is really about 51% versus 50%. So it's not that somebody needs to have definite sort of advantage over of one side over the other, but it is to say that, do you think that on balance of probabilities, is it more likely that this person did and less likely that she did not do? So the balance is really 51% versus 50%. So it's not confirmatory. But on the balance of probabilities, you needed to have determined that they were unable to do any of those sorts of things, which is really about understand the information, retain that information, weigh it up, and then be able to communicate that sort of decision. So basically, what happens is, I think there have been plenty of challenges, and I think in some areas what they've really said, and the courts have sort of determined that really what you need to be clear is that they're functionally able to make that decision, and sometimes if they can functionally make that decision, then the question of diagnosis really doesn't apply. So how do you do a good capacity assessment? You need to be clear about the decision. So capacity is not a blanket statement. So capacity to gift may be very different to capacity to agree for a treatment, which may be very different to capacity to I don't know, accept going and living with somebody else, etc., etc. So the decision has got to be specific, and you've got to be clear that you're assessing the decision that needs assessing. And then you need to have given the person the concrete details of the choices. So they need to know what is the offer that they have. So what is on one side and what is on the other. So more often, I think you'll find, perhaps in people with slight sort of autism or slight sort of Asperger type sort of background situations, that you literally have to make them live in two different environments in order to be able to choose. So an example which is given is, if I showed you a coin, and if I showed you a head of the head on one side, automatically you will realize that there is a tails on the other side. But sometimes some people, perhaps with autism or Asperger's, will not really know that there would be tails on the other side if they're shown head. So an example which is given is, you need to show them the head and you need to show them the tails, both, and then they will be able to make the choice. So literally this happens sometimes. What we have to do in clinical situations is we've got to try and place them in a residential setting for a little while, and then place them in a different setting, and they have to be able to compare between the two. So you have to give them the choices. I mean, these are difficult practically to do, but that's what the law sort of says, really. You've got to be able to do that. And can they understand and comprehend, and so on and so forth. So you've got to need to have demonstrated that all efforts have been taken to promote their ability to make a decision. And if they've got any impairments, etc., you've got to have helped them to do it. So the presumption is in the favor of capacity, really, for the decision. And as we've talked about this. So is it really on balance of probabilities? It does not need to be what is called as beyond reasonable doubt, which is a slightly different test. We've talked about best interest. I'm going to slightly, in the interest of time, I'm going to try and get on to the next sort of thing, which is really, I mean, all of these things you will find in the PDF that I've sent it across. But I want to move on slightly to something else, which is this, that, it's quite, you can see how perhaps such situations lend itself to exploitation of different types. I mean, we talk of elder abuse. I mean, it's elder abuse, but it could apply to anybody with mental illness, really. And we know there are different types of abuse, and it's been quite clearly codified in some ways. So I think people have become more aware of the different types of abuse. But as you will see here, I mean, there are things that don't neatly fall into these categories. And what I'm talking about is one of those things where there is some sort of emotional coercion, or there is some sort of advantage and exploitation, but it doesn't necessarily fall into any of these different categories. But it is true that this is a hidden problem, and it's estimated that 1 in 6 have been sort of abused worldwide. And these are only the categories that we are aware of. And as I've alluded to, there are other areas where things are happening all the time. And it's consistent. It's consistent across all sorts of areas. I mean, across the world. So no one area is free of this. But if you look at this graph, I mean, I think this is what is called as emotional abuse, but it doesn't really meet the threshold, and it's quite high. So I wonder whether what we're talking of will fall perhaps here and may somewhere along those lines, and it's not being recognized or recorded. It is well documented in India. I don't need to tell you as an audience, and I've just sort of got some figures just to emphasize the importance of it. It's quite clearly documented in a number of studies all through. But the consensus is really that this is an underreported problem. And generally, I think it's not quite easy to recognize that. So it is common. It can happen in all settings. It can happen at settings at home as well. And this is perhaps what I'm trying to allude in this. It can happen in institutions, and only some of it is reported. And we all have a duty to be aware of this. and we have got to try and prevent all these abuse. And there are some strategies in many Western countries have adopted in order to try and tackle this. And we have got what is called as safeguarding, which is a multidisciplinary team, and it's led by social services, leads to investigation, and then reports to police. And I think what I'm trying to allude is, I think it's quite common if there aren't any structures, perhaps in situations like what you'd be facing, that these structures are not there to protect. And of course, a lot of these can remain hidden and can go below the radar. So in the Western world, there is something called an Office of Public Guardian, which has been a statutory body, which has been developed mainly to try and deal with a lot of these sorts of problems. It includes things like abuse of health and welfare, power of attorney, finance, property affairs, and those sorts of things. And if there are abuse issues that are picked up, then they get reported there and they get managed. I mean, some of the case examples that I've dealt with are quite horrendous. So I think it's difficult to believe, but I think the older generation in the Western world is for various reasons financially well off and better off than the younger generation, and the younger generation turn out to be the attorneys looking after elderly parents or grandparents, and the amount of times that money has been misappropriated, they have been into inverted brackets gifted to the grandchildren or gifted to others, and I think it doesn't get picked up until something happens, a statutory body gets involved, and then finally a big sort of investigation is commissioned, and then some of the attempts are done to get some of these monies recovered. I mean, translated into an Indian setting, you can just imagine that without any statutory body, without any statutory oversight, the mental health patients, how compromised they can be. And I mean, admittedly, the family do protect and do look after them, but also stand to occasionally be people who might take advantage of. So I think we just need to be mindful and more aware, I think. And so here we've got what is called as a Court of Protection, which is really a very statutory body, which deals specifically to deal with these sorts of cases. And I'm just sort of using this opportunity to highlight that perhaps we need to think about such sort of bodies, or perhaps some sort of statutory ways to deal with this, not just in the Western world, but in all sorts of settings, really. An august body such as Indian Psychiatric Society, or indeed some of the key members in this esteemed audience, may be an important group of any work that could be undertaken in this area. So with that, I stop. I will stop and take questions if people have got questions.
Hari, not a question, but a comment. I think you must elaborate a bit more about the probabilities and the other thing, which is, quite, the nuances are not that easily understood. And no. Second thing, just a minute, please. Let me finish, Hari, if you don't mind.
Yeah.
The other thing is about the neglect, the emotional abuse, and the gradations between them. That I think you must elaborate a bit more. At least from my, these are my queries. Okay. Thank you.
Okay, so I think the issue of probability is often a difficult one, really, and I think this is where let me sort of clarify with an example. So a typical situation would be that an elderly lady would have had, I don't know, £5,000-6,000 taken out of her account by perhaps her son. Her son will say that. I take her out to get her shopping. I do regular shopping for her, and I need to take her out in comfort. And therefore, she told me to get a new car, and therefore this money was used as a car, which is used in order to provide her the services that is needed. And so she had the capacity to gift me that money. What might be the case is this will come out only about, I don't know, 8-10 years down the line, where perhaps she needs to go into care, and all her assets are being scrutinized by statutory bodies. And so they will come up with this question: is do you think that she had capacity at that time to give him that amount of money? I mean, it's a very difficult question, really, and I think it's often a very subtle judgment. I mean, the son, I don't think is intentionally wanting to do it, but I think he's not exploiting, but he's taking slight advantages, which perhaps maybe he would not have had he did not have access to some of the benefits from her situation. So, what then happens is a retrospective investigation is conducted, and you've got to try and establish from her, from the patient, by talking to her, what is her best interest. Would she really have wanted this? Would she have sort of made such a decision, or is it likely that she didn't understand at all, and really the son was just sort of using it as an opportunity? And what you do is try and gain a retrospective view on the abilities from her GP notes, the functional abilities, what she can do and what she can't do. And this is where you need an informed opinion. But sometimes these decisions are very difficult. And in the courts, you could have two different set of lawyers arguing two different things. So I might, as an expert witness, say, as a court of protection visitor, say that maybe actually she did not have the capacity, whereas there could be a lawyer from the other side which says that it is quite it's quite possible that she was wanting to do, and ultimately the court has to make a decision. So these are challenging decisions, sir, and I think but the legal framework is you don't need that to be beyond reasonable doubt. So it should not necessarily be like 70-30 or 80-20. It's just 51-50 is enough. Because the other sort of beyond reasonable doubt is a threshold which is used for criminal sort of cases, and these are all civil, and the civil is decided on balance of probabilities. I don't know if it helps answer the question.
Yes, definitely it answers my question. Thank you. Next is about elder abuse, the gradations between neglect and emotional abuse.
Yeah, I mean, again, this is a very gray area, and this is where the problem is. I mean, I think, sometimes it's easy to underestimate. Looking after people with mental illness can be exhausting, can be quite challenging, can be quite difficult, and families might be doing a hard job under extremely difficult circumstances. So, I think it's very difficult. So you might sort of find that on balance of probabilities, the families are doing a better job than not. And again, is it an emotional abuse, or is it just that they're tired, they're exhausted, they can't really do, and therefore they snap back? It's a very difficult decision. And I think no two practitioners might come to the same view. And so therefore, it does require a multidisciplinary approach with various professionals, some who might have known the patient better, not just from a medical angle, but from other angle, families and friends, perhaps. In the Western world, it's easy because there's social services and quite a few other agencies. But actually, in the Indian world, in Indian setting, it might just be the family. So it's a very nuanced judgment as to whether we think the families are slightly overstepping the mark, and that can be quite difficult.
There are some questions here, chat box.
Yeah, I'm looking at it. So one of the questions it says is challenge in capacity assessment when the patient is aphasic. Yeah, I mean, I think this is well recognized in courts. So I think what they would say is in situations like these, where somebody cannot speak, then we need to use other techniques. So the other techniques could be about a card, for instance, which would say yes or no. And I think you want to try and frame your questions in a way which says yes or no, and then ask them to point that card. Sometimes they may be able to use, this is more useful in people with learning disabilities. They've got various visual ways of depicting pictures. They will communicate through non-verbal means. So you've got to try and explore all the other ways to approach communication. So even if they're aphasic, they may still be able to communicate. It's just that we need to find the way by which they can communicate better. So it could be non-verbal ways, by body language, by head nodding, by finger clicking, by repetitive sort of movements, or perhaps using yes or no cards. And there are some various blocks which will have pre-written answers and they can choose it. But it's a specialist area in itself. Does that help? Is that what they were looking for?
Yeah, you have done a good job. Thank you. Hari,
I am mindful that it doesn't cover everything, but it's a big topic. So I've given people some PDFs so they can sort of refer to it at leisure. Is there any other questions for me, sir?
Thank you, Hari. We are running out of time, and so I'd go to the next speaker. But definitely, we'll meet in person in December, and then we can continue. You'll be free to. Yeah, okay. Thank you very much. And
thank you.
Now I'm going on to the next speaker, Dr. Ramesh Shankar, who's going to talk on COVID pandemic and its effects. Can I call on Dr. Ramesh to start his topic? Thank you.
Good morning. Good morning and good afternoon, everyone. I am Ramesh Shankar. Let me first thank Professor Rajkumar, who, am I audible?
You're very much audible. Thank you. Please continue. Please continue.
So good afternoon, everyone. I'm Dr. Ramesh Shankar. I'm a consultant psychiatrist in general psychiatry, as well as the clinical director within Lincolnshire Partnership NHS Foundation Trust within the UK. We are one of the forerunner trusts with an excellent CQC ratings, which is the regulatory body for most of the mental health trusts and the acute care trusts in the country. And we have an excellent standing by the CQC. So I work in a very privileged institution. And I should at the outset thank Professor Rajkumar, who I had been known to since the early 90s. He was my teacher, friend, philosopher, and a guide. And we have kept in touch all these 30 odd years. So Professor Rajkumar, very many thanks to inviting me for this conference, and thank you very much. So I'm going to now share the slides, and I will go off the camera and start discussing the topic, if that's all right with you. Right, okay. So the topic for today's discussion is physician burnout during COVID-19 pandemic and mental health support. Why is this topic relevant to healthcare professionals and particularly to psychiatrists? Why a psychiatrist is going to talk about this particular topic? I'm in my mid-50s, and many of you would be really young in the audience. Many of you would be in your middle ages, and some of you would be past your 60s. If you look at the way how life has gone on over the years, from the early 80s, 90s to what we are now, life has become very competitive in all walks of life. It has been like a rat race. The expectations in the society is growing up by the day, whether it's your personal life, whether it's your professional life. You are being watched in different ways by the different aspects of the society, whether it is the patient or the carers, or for that matter, your family, your children. The expectations are higher. And more so, the regulatory body, the expectations of you as a professional has gone up significantly with significant clinical governance issues. I've been living in the UK for the past 25 years, and I have seen the governance of the regulatory body and the institutions have gone up significantly over the years. And more so, I can vouch for the same with the Indian context as well. Fortunately, I have been in discussion with the IMA president, who happened to be my classmate, Professor Jailal. And he has been telling me that over the years that the regulatory body within India are also having significant expectations from the professionals, which is good in one way, but it is going to have some impact on the burnout of patients, which I will come to during my presentation at a later stage. So one would expect that generally people are getting stressed out in life because the expectations are too much in the society. And more so, we as healthcare professionals in the walk of life where we are here to save life and keep the well-being of people at the best possible level, we are expected by the regulatory bodies to be performing at the highest possible level. Within the UK, the most scrutinized professions are two, namely doctors, followed by pilots, because we are directly having a significant impact on life or lives, whether it is saving or protecting and other aspects of human lives. So on that note, I would like to deliberate this topic, focusing on 6 distinct headings. The first one being, I would like to discuss this topic on introduction to physician burnout, followed by the history of pandemic, what we as human race have seen, and the physician burnout associated with that. Thirdly, about our current pandemic we are facing, which is the COVID-19 pandemic, followed by the impact of this COVID-19 pandemic on the physician burnout, and what is the mental health support we have currently available, and the recommendations from the reading I have done, the research I have done, and followed by the references. So these 6 headings I'll be focusing the deliberation on today. So let me go on to the first heading, which is the introduction to physician burnout. So when you say burnout, obviously one would expect what is the definition of a burnout. West et al. In 2018 defined the concept of physician burnout as a work-related syndrome that involves 3 components, namely emotional exhaustion, depersonalization, and a sense of reduced individual and professional accomplishment. So please remember, it has got 3 components. Number 1, emotional exhaustion. Number 2, depersonalization. And number 3, reduced individual and personal and professional accomplishment. So when you look at the factors which contribute to the burnout, I have clubbed them into 5 distinct categories, namely systemic factors, endemic factors, interpersonal factors, environmental factors, and socio-cultural factors. So when we talk about systemic factors, there are multiple things you can think of in systemic factors. For example, when you have a poor work-life balance, that people are working constantly and not having enough time spending with friends and families, not having recreational activities. That is one particular example you can think of. Then you can think of other examples like, for example, you are working in a big institution, in the Western world at least, Professor Rajkumar would also agree with me that when you have rotas here, doing on-calls during the nights, if you have frequent on-call rotas, you are expected to have a significant burnout. Like that, if, for example, you're working at a consultant level and your junior doctor is not turning up on the day for the on-call, you are expected to cover. So you have to step down at the level of a junior doctor and you're expected to cover on the day. And if that happens very often due to sickness, then it is going to have an impact on the burnout. Now, coming to endemic factors, I specifically want to talk about traumatic events When I say traumatic events, I'm talking about events which happen not in terms of the individual, but in terms of the work as well. For example, there are certain institutions where it is endemic for various serious incidents because of lack of clinical governance. You don't have proper training, and that can lead to significant burnout because you are constantly under pressure and a threat from the practice that is being done over there in that institution. I recently understand from various newspapers that it has become an endemic situation in certain localities in India where doctors are being threatened by families of patients for various reasons. So it is not unique to one part of the world. It is quite being apparent in various parts of the world. Coming to interpersonal factors, what is that we are looking at? As you know, those days when I became a medical student, we had, and I came from Tamil Nadu myself. When I went into medicine, there were totally 600 MBBS seats in the whole of the state. So the competition was very different at the time, but people who had the passion of getting into medicine got into it. But there is now a lot of pressure from families to get into medicine. The number of seats have gone up, and the expectation of the society have gone up as well. So generally, people who get into healthcare profession, they are quite aspirant. And most of them, I would say, not everyone though, but most of them would want to be a perfectionist or highly aspiring. And most of them, they somehow slip into the type A personality, and they have this fear of weakness. I do know that recently in India, there has been entrance postgraduate or as well as undergraduate entrance exams to get into medicine through a national system. And I do know that there has been significant suicides amongst even school students because they were not able to achieve the grades and get into the medical schools. So if you look into it, the burnout starts even before getting into medical school because of the high pressure they are in. So we need to be aware of that. Then coming on to environmental factors. So this is significantly talking about workspace and the workplace environment, as to whether you are working with good colleagues, whether you are working in a good environment, whether there is enough break, whether the lighting is adequate, whether the ventilation is adequate, whether you have a canteen facility available. There are so many factors, and how your management is looking after you. It's very vital. If any of the management staff over there from an institution, they need to be aware that the burnout of physicians is going to be important, significantly important and critical for the reasons which I will highlight later. Then finally, coming to socio-cultural factors, as a doctor, you have your own personal lives, you have your families, and there will be a lot of pressure from your families, and friends, and financial pressures, whatever, that is going to have a significant impact on your burnout. So I thought this is a good way of analyzing the factors, clubbing into these 5 factors. Now, how is burnout being typically assessed? Now, we have the most commonly used 3 tools. The most commonly used is found to be the Maslach Burnout Inventory, commonly known as the MBI, the Job Diagnostic Scale, JDS, or the Ulrich Work Engagement Scale, or the US. So now you remember from my first slide, what is meant by burnout? What are the components? I mentioned about 3 components, namely emotional exhaustion, depersonalization, and reduced individual and professional accomplishment. So Maslach Burnout Inventory is based on these 3 categories. So what is the first one? Emotional exhaustion talks about, or what does it measure? It measures the feeling of being drained of energy due to one's work. So it is going to measure how much the person gets drained of the energy based on their work-related stress. The second component we will be talking about, as you remember, is about depersonalization. What does depersonalization measure? It measures the extent to which one has ceased to empathize, which means when you have a patient, due to burnout, you might expect a healthcare professional not to empathize with the patient. When you don't empathize with the patient, naturally, your quality of care, your interpersonal relationship, everything goes down. And the outcome of the patient care is going to be significantly affected. Then finally, what does reduced individual or professional accomplishment means? What does it measure? It measures the extent of job satisfaction. So it could be self-critical, and it might lead to the individual, the healthcare professional, not being happy about the job, and that is what it measures. So if you look at all the three items of the scale, it has got scores of low, average, and high, whereas when you talk about the burnout, it talks about low, medium, and high risk. And it also can measure whether you are in burnout or not. So it has got about 22 questions, and that is how it works. Now, why is burnout important? The burnout is significantly important as far as efficient goes, because it is going to have an impact on serious or dire consequences on patient health, physician health, and the healthcare costs. So let's talk about what's going to happen with the patient's health, how it is going to affect the patient's health. So when you have emotional exhaustion or any of the symptoms of burnout, then naturally your interpersonal relationship with the patient is not going to be great, because you're not going to empathize with the patient, and you are not going to be in your own spirits to communicate with the patient properly. So when you don't have proper interpersonal relationship, you will not develop that therapeutic rapport or alliance with the patient. And that can lead to, a dissatisfaction from the patient. However, it can also lead to significant medical errors, because you would not be able to concentrate on what you're doing, and because of your emotional exhaustion, as well as your depersonalization symptoms, you might not be concentrating appropriately and adequately with your work, and that leads to significant medical errors. And also it increases the amount of malpractice. Why does malpractice happen? Because you want to prove a point, despite your exhaustion, that you want to do something to help the patient, but that might end up with malpractices. And this also would contribute to the reduced or minimal patient satisfaction. When the patient doesn't get satisfied, naturally you would expect the outcome to be low, which means the quality of care overall is going to be significantly reduced. And that is going to have an impact on the institution, as well as the reputation of the healthcare professional, and finally, the whole reputation of that workplace is going to be affected. So what are the consequences on the physician's health directly? As you all know, what we have just now described, the physician can experience all the symptoms, what I described earlier, which can lead to increased substance abuse. When physicians do experience burnouts, they want to have an outlet. They might take to alcohol, or they might take to drugs, and which can lead to significant increase in the substance abuse. 1 minute, I'll just drink some water. Okay. So, when the patients are exposed to significant alcohol or drug abuse, obviously one would expect an increase in motor vehicle accidents, and we do have a support system in the UK for doctors called as NCAS, which will look into all these issues. And also, the suicide rates amongst physicians have gone up over the years, mainly because of that. When you talk about suicide rates, female physicians are more prone, and they are about 2.27 times more than the general population in terms of completing suicide compared to male physicians who are 1.41 times more than the general population. Now we'll be focusing on the healthcare costs. So what is what is going to be the impact on the healthcare cost? If a physician is not happy with his job and he has got significant burnout, what is going to happen? He might or she might decide that it's not worth working at the place. And that is going to have a significant impact on his decision making. And it might be an untimely departure of the physician from the workplace or the institution. And there are studies being done in the US where they talk about to replace a consultant level physician, you're talking about spending anywhere between $250,000 to $1 million for replacing the consultant immediately. In the UK, we have locum agencies where we spend money through the nose. I as a clinical director, sometimes I have to frown upon the expectations of the cost because we all have tight budgets internationally and we have to work within our stringent financial situations. And it is very vital that if you take care of your own folks, then the retention rate is going to be very high. I now remember the words of the great Ratan Tata as well as Sir Richard Branson, who is the owner of the Virgin Group. These are the two business giants, and I adore them big time because one of their golden words is, you look after your staff, the staff will look after your clients. And this is a mantra I would suggest to any management staff, that if you look after your staff will look after your clients. So it is something every management staff should learn, that they are there to look after their staff so that the staff doesn't have significant burnout, their turnover rate is not that high, there is significantly high retention rate, so that recruitment also gets better within the institution. As you all know, within the UK, we have significant shortages of healthcare professionals, irrespective of any discipline. And within our division, within our trust, like any other trust, we are facing shortages in various disciplines of work. So it's not only about the money; it's also about if you don't have enough doctors, if you don't have enough healthcare professionals, obviously it is going to have a significant impact on the continuity of care of the patients, and it is also going to have significant impact on the quality of care you're going to provide, and that eventually comes down to the reputation of the institution. And not only that, you have to also understand that you have to spend as an organization significant amount of monies to train people to get to that level once somebody departs. So it is important that everyone gets into that mindset that the burnout of physicians is very critical for any institution, as the physicians carry the can for the patients. Let's focus on the second heading, which is the history of pandemic and the physician burnout. So I would like to start from the 14th century. I'm sure every one of you would remember about plague, the Black Death, which happened way back in the 14th century, where the estimated death was around 75 to 200 million. And we all know the bacterium Escherichia pestis caused this. And that was the first sort of really documented pandemic in our planet. Followed by the 18th century, we had about 13 fairly severe epidemics at the time. And in the 19th century, we had about 12 epidemics. Of them, specifically, 8 of these 25 were found to be influenza pandemics, according to the WHO. Then what happened in the 20th century? You all know and would vividly remember, would have heard from your parents about the Spanish flu, which happened due to the H1N1 virus, which started from the US way back in January 1918. We call it as the big influenza or the big divide. You'd have all learned in the social and preventive medicine. I learned it at that time in Park and Park, the great Spanish flu, and we lost, the estimated loss was around 50 million deaths at the time. And despite the fact, around those times, the international transport was less, but still the influenza virus was so virulent. And I think in recent history, that is considered as the most severe and dangerous influenza pandemic we had. Then we had the Asian flu, we had the Hong Kong flu, we had the swine flu, the Russian flu, and recently the avian flu. So talking about the 21st century, we had this swine flu virus way back in 2009, 2010, caused by influenza A. The deaths were considered to be anywhere between 100,000 to 400,000, but certain research has shown that the death was around 254,000. There has been, unfortunately, no publication of data from any authentic agency about the fission burnout regarding the previous pandemics, which is quite sad for us. Let's now talk about the current pandemic, the COVID-19 pandemic. Just to give you some numbers, United States, the confirmed case was around 43.6 million, and the deaths were around 701,000, followed by India, where we had estimated deaths of around, confirmed deaths rather, of around 33.6 million. The deaths were around 449,000, followed by Brazil, where the confirmed cases were 21.5 million, and the deaths were around 598,000, followed by the United Kingdom, where, even though the total population is 63 million, we got 7.87 million patients were infected, and we had around 137 deaths, followed by Russia, 7.45 million confirmed cases, and 205,000 deaths. So worldwide, we had around 219 million confirmed cases, of which we sadly had 4.55 million deaths, which is amounting to approximately 2.25% death of the confirmed cases. So what has it done? What has it done to us in terms of fission burnout? This particular pandemic, it did create a havoc in various people's lives. And if you remember the 5 different areas I talked about, which contributed as a factor, is a social cultural factor. And I mentioned about families and friends in that. So if you, personally, I have lost a few colleagues. We lost one of our colleagues in our institution during the first pandemic. He was a classmate from my own batch due to COVID. So across the world, we have lost friends, and I had lost a few cousins as well. So it has put us in significant difficulties. We are not able to travel from UK at that time. And likewise, I have heard stories from many of my friends and families that how directly or indirectly it has affected everyone in some shape or form. So let's look at the global perspective in a scientific manner in terms of research. So I mean, obviously, we all know this COVID-19 pandemic started from China. So at the beginning, Wu et al. Did some research on the fission burnout, and he first explored the prevalence of burnout amongst the medical staff in China, of which 220 physicians participated. And interestingly, only 23% of the physicians had felt more burnout compared to the normal situation. And 15% of the respondents neither disagreed nor agreed to feeling more burnout. And very interestingly, 62% disagreed to feeling more burnout. But please be mindful, this started at the beginning of the pandemic. However, it is also interesting to note that there are significant cultural differences on resilience, on burnouts, and the word stress. It's used in different contexts in different societies. So compare this with Northern Italy. Guesti et al. Surveyed healthcare professionals working in a health institution in the Northern Italy, of which 330 healthcare professionals participated. And more than 2/3 of the participants reported moderate to severe levels of emotional exhaustion, which is the first component of burnout, and reduced personal accomplishment, which is the third component of the burnout. And more than 1/4 of the sample reported moderate to severe levels of depersonalization, which is the second component of burnout. So if you add or sum up these two, we are talking about nearly 75% of the sample, which has shown significant burnout. And that correlates very well with the study done by Dimitri et al. In Romania, who also assessed burnout using the Maslach burnout inventory, of which he had a sample of 100 medics. And here again, you can see 76% of the sample reported burnout. And the authors noted that the level of burnout was superior to the studies conducted in normal periods. So it is important that we have to understand about the social context, the cultural context of the word burnout, how different societies and cultures view burnout, and how resilient some societies are, and how resilient some communities are compared to other parts of the world. In the Western democracy, as you all know, the concept of family, generally, the concept of marriage as an institution, it has been gradually eroding, and the spirituality has been gradually eroding in the Western society. And the state behaves like a big brother, and it takes care of its citizens. And there is an expectation of entitlement from the society towards the state, because the family has been slowly, the concept of family has been gradually eroding. And in the past, when I was a kid, we used to have joint families where grandparents, parents, children, and grandchildren used to live together in the same household. I still, explicitly remember my childhood days where I used to go to my grandparents' house, and there will be tens and tens of people, and we used to have a very good time. But nowadays, hardly you have that concept even in India. We are more focused on nuclear families. So it's having a significant role in terms of burnout. Now, talking about UK. Okay, British Medical Association is a trade union, and it looks after the doctors, and it did do a survey in the middle of the pandemic, and the survey was sent to nearly 6,000 doctors, of which 4,500 doctors responded. And we found out that, interestingly, 51%, a whopping 51%, more than half of the doctors do not feel supported by their workplace at the time. I mean, this was done around the time when PPE was a shortage within the UK to begin with. And the government was significantly blamed for its inaction at the time. And many of the workplaces, they were not having enough PPE, and doctors were being asked to do their job without enough PPE at the time. And so that might reflect as to why 51% of the patients 51% of the physicians were not happy at the time and not being supported by their workplace at that time. Around that time, there was a significant increase. There was a significant increase to the staff well-being service of the British Medical Association by the medics. 40% of there is a significant increase of 40% during that time to get that support from the British Medical Association. In a normal time, when you look at doctors within the UK, 44% of the doctors were already suffering with either depression, anxiety, stress, burnout, emotional distress, or any other mental health condition related to work. This is at normal times. But during the pandemic, 29% of them found that it did have a direct impact on their burnout. So now we understand that both in the global perspective as well as within the UK perspective, COVID did have an impact on physicians' burnout. Now, coming to the Indian context, even though burnout and work-related stress have been studied widely in the Western and developed nations, as well as developing nations, there has been a paucity of the data from the Indian context. A systematic review conducted by Keswani et al. Highlights that approximately 1/4 of the Indian healthcare professionals suffer from burnout. And he has recommended that to improve the physician burnout, they have to have scheduled staff meetings, encouraging cooperation and discussion between professionals, and also to conduct workshops to improve coping skills. So even in the Indian context, you can see with the limited data available, nearly 1/4 of the healthcare professionals have gone through significant burnout, and more so, the burnout among physicians has been the case. I was talking to my younger sister, who is also a doctor and a professor in SPM department in one of the government medical colleges in Tamil Nadu. She was telling me that the expectations of the government for primary care GPs at primary health centers in India, they were being expected to be working on Sundays, almost on a weekly basis lately, due to the massive immunization programs. And whether they are given in leave any off days, it's a hit and miss. So I think it is important that the government, the management, everyone understands that healthcare professionals are also humans, and continued burnout on them is going to have a significant impact in the quality of service at some point in time. Now, what is the current mental support available? Let's have a look at it. So I'm going to talk about this and club this into two different distinct categories. One is physician-directed intervention. The other one is organization-directed intervention. So when you say physician-directed intervention, what are the things we can think about? Obviously, in the Western world, we talk about mindfulness techniques. We provide stress management techniques to individuals, physicians, and counseling based on educational, cognitive, and motivational interviewing, as well as we direct physicians to staff well-being services. Now, talking about organization-directed interventions, the various methodologies and the various mental supports available are reduction in the workload by improved teamwork. What I mean by saying that is, if the organization can look into proper multidisciplinary approach, wherein there is no expectation single-handedly on the healthcare professional, especially the physician, and taking a team approach rather than just finger pointing at a doctor that he is responsible for everything. If you have a team approach, then that reduces the workload as well as the caseload of a physician, which can help in reducing or alleviating the burnout of physicians. Then effective job planning. We have been doing job planning in the UK for many years now, that we look at the amount of hours a physician is being contracted and what are the expectations of their job, the roles and responsibilities, how their clinical activities, that is a direct clinical care, has been awarded in terms of personal relevance, and how many supporting professional activities can be provided. Within the UK, we have the national terms and conditions for physicians at consultant level. Out of 10 PA, which is a 37.5 hours contract, 7.5 PAs personal relevance, so it is about 3 days and the quarter, 3.75 days of the week will be on direct patient care, and 1.25 days will be for the physician supporting activities like the research, teaching, and their special interest sessions and whatnot. So you have to have a proper balance of their work. And I'm really proud and privileged to say that we, within our trust, Lincolnshire Partnership Trust, with the help of our medical director, Dr. Anantha Dave, who is going to be the next speaker for today, she was leading, along with our colleagues within our trust, the risk assessment tool, which has been approved by the Royal College, and the whole country sort of followed our model in doing the risk assessment tool for doing the risk assessments on physicians as well as other healthcare staff during this pandemic, as to whether they are appropriate to come back to work, whether they have to be working in isolation, whether they have to be whether they can be doing face-to-face contact. So that did help in reducing the burnout. And as you all know, if you had been following the international news, during the first wave of the pandemic within the UK, especially among the healthcare professionals, a significant disproportionate number of BAME community, which means the Black and Asian minority ethnic physicians, sadly passed away. I'm not only physicians and also healthcare professionals from this community, Black and Asian minority ethnic community, disproportionately sadly passed away. And the government, there was a lot of debate on this in the parliament, and special attention has been since then paid to the BAME community, physicians and healthcare professionals. And I'm also happy to mention that our medical director, Dr. Anantha Dave, she is now in the select committee of the parliament, representing as an Asian doctor and the first woman of Asian origin to be representing in the parliament in the health and select committee. And she has a strong voice on the equality of the BAME healthcare professionals. And every organization should have a staff well-being service. That means that you can look after your own healthcare professionals and provide the necessary support as and when it is appropriate and required. So what are the recommendations I would like to propose based on the reading I have done, the research I have done? So these are the recommendations. So we need to have formalized burnout reduction programs in a very open and confidential manner outside our establishments, which has to be approved and recognized by our institutions. And online or telephonic access to our physicians who suffer with burnout through trained mental health professionals, maybe psychiatrists or trained counselors, should be made available. Currently, we do not have a support program for spouses and dependents of physicians who suffer with burnout. We don't have, as far as I could see, in any part of the world. I think that is one proposal we should have, because a physician is part of the family, and it is going to have a significant impact on the family. So support programs for spouses and dependents has to be there. And also, we should focus on training even at the stage of medical school and residency education. I would like to highlight here by stating that the highest burnout starts or gets initiated at the time of training as a medical student, but it peaks at your residency program, where the number of hours you do work are significantly high, the pay is not that great, the expectations are tremendous, you have to sit for exams, prepare for post-graduation exams, you have to do audits, you have to do research, you have to impress your consultants to have future jobs. The expectations are too much on you. So I think the residency program is very, very critical, and research has time and time again shown that the burnout amongst doctors is significantly high at residency program or residential education time. So on that note, let me say thank you to all of you, and these are the references for my lecture, and where I have read all the papers from. And I would like to conclude by saying, please take physician burnout as very important. If you go back home and reflect yourself today as to what the symptoms you have, or what you had at some point in time, you would realize that at some point in time, you would have potentially had one of these symptoms, what I described out of the three. So please do take care of yourself, and recognize if one of your friends or anybody who do come across with any of the symptoms, that could be a sign of physician burnout, and they have to be given due attention. And of course, you support them to the best of the possibility. And I would urge, if there are any management staff, please look after your clinical staff, because they are the ones who is going to drive the quality and not the non-clinical managers. Because one of the significant result of late, which has happened in the Western world, is the target culture. And there has been plenty of reports, at least within the UK, I can talk about, and most of the reports talk about targets, which was given more focus than actual patient care. So you miss the trees for the woods. That's what I would say. So on that note, let me conclude. Thank you very much, and wish you all the very best. Have a wonderful session. The next speaker, Dr. Ananta Davi, my medical director, she's also an excellent speaker. I'm sure as a child psychiatrist, she will provide a fantastic deliberation on the topic. And if you have any questions, I'm more than happy to address now.
Ramesh, a well-presented talk. I have some comments rather than questions. One of my doubts is, how does the individual physician cope up without having access to, this formal, workplace-based interventions or system-based interventions? Because that kind of a luxury is not there in India. We have studied our interns and postgraduates who have been working on COVID-related issues here in our hospital. The studies, the results had been presented earlier in the morning, and some of them are actually taking off and going away rather than meeting the issue. One more thing is, a lot of work has been done in India, and you have quoted the Indian Journal of Psychological Medicine. There's also a supplement by the Indian Journal of Psychiatry last year, which has talked about various aspects of COVID-related issues among physicians and medical students and things like that. There's a supplement actually. It's quite a wealth of information there in the particular art in the journal. Overall, a very well presented topic. Thank you very much. And I would like to respond on the individual approach to the management or individual coping skills of the physicians. Thank you.
Thank you, Professor Rajkumar. As far as the individual approaches are concerned, I think it's basically you need to be able to have insight into it as to whether you do experience this symptom. It's about self-awareness as to whether you are going through the burnout symptomatology. If you are going through it, seek support. I'm not sure whether you can manage it by yourself, but you have to have a proper work-life balance. And I always insisted on that. So, I also, because I come from the same culture like most of you, we are very much focused on work, where we ignore our families and friends. And we don't understand that work is part of life. Work is not everything about life. We are not born to work. We are born to live, and work becomes part of life. So as long as you are aware of that and have work-life balance, because I do know many of my friends and junior colleagues from my medical school where I graduated from in the south of Tamil Nadu, when they became busy clinicians, they completely ignored their families. And some of them sadly passed away at a very young age due to either myocardial infarction or some other illnesses, because they completely neglected themselves and focusing predominantly on work. They used to spend about 18 hours, 19 hours in the theater because they were so busy. And we have been focusing on either on materialistic benefits or on fame. I think every one of us should realize that we have families, we have friends, and we should strike a balance. And if we can't resolve it ourselves, I think we have to take support from our psychological colleagues or psychiatric colleagues. Thank you, Professor.
Thank you very much, Ramesh. I think for the excellent talk. We'll have to go on to the next topic. I think if I know you were supposed to have it after lunch, but if Ananta is ready, maybe I could ask her to start the talk. Ananta?
Yes, good morning from the UK and good afternoon in India. I am ready to do my talk if you think it's the time is right now.
Please go ahead. Yes.
Okay, fine. Thank you. I'll try and share my screen. If I have any problems with sharing, I believe you have a copy of my talk as well, and I might request one of you to do the slides for me, but let me just try and share my screen.
Okay. Okay.
Just give me a minute. Can people, okay. Can you see the screen? Can people see my screen?
Yes, Ananta.
All right, okay. I'll try and see if it continues to work. Okay, fine. So before I continue the talk, I just want to say a huge thank you to Bharat Medical School and College and Hospital, and to Professor Rajkumar and team for inviting me to do this talk today. I'm Ananta Dave. I'm the medical director at Lincolnshire Partnership NHS Foundation Trust and a consultant child and adolescent psychiatrist. You just heard my colleague, Dr. Ramesh Shankar, give an excellent talk on physician burnout. And I'm going to be talking about a topic which is very close to my heart in my professional life, and I think something which is becoming of increasing relevance and importance everywhere in the world. So my talk is on preventing self-harm and suicide in children and young people, specifically with a focus on the impact of COVID-19. So I'll touch upon what happened before COVID, but also looking at what is happening now post-COVID. So yeah, can people see my slide now? Has it changed? Just want to make sure that my slides are moving.
Yes, Ananta.
All right, thank you so much. So just to give a background to where I come from. So I was born in Andhra Pradesh in India, in Rajahmundry, but then I lived most of my school, childhood life, and my early adult life in Bombay or Mumbai. And you can see a photo of the Gateway of India on the left side. I then came to Birmingham in the UK. You can see a photo of Birmingham Library there on the lower left-hand corner. And then afterwards, after working in Birmingham in the West Midlands part of the UK for several years, I moved to Lincolnshire, which is, you can see glimpses of Lincolnshire, the cathedral, and the place where I work, and the CAMS service, that is the Child and Adolescent Mental Health Service in Lincolnshire, which is a very active, so the whole trust has got a very dynamic approach, I would say, to learning and professional development. So we have a very active medical education department as well as a research team with links to the University of Lincoln, and several of our colleagues also work at regional and national levels in various aspects of policy. And we have mental health services, learning disability and autism services across the lifespan. So my talk, as I said today, will be about self-harm and suicide in children and young people. So although the bulk of my talk focuses on what happens in the UK, as that's where I've been working for the last over 25 years, I will be relating it to what is currently the situation in India. And of course, I'm sure you all will be much more familiar with and aware of what's happening in India currently, but I'll just try and link what's happening in India and how we can learn jointly and how we can identify common priorities for us to do the work required in preventing suicide in children and young people. So the outline of my talk is suicide in pre-COVID times. And as I said, this is in relation to children and young people. The impact of COVID-19. So I'll talk about the direct and indirect impacts of COVID. So I'll spend some time looking at the context of COVID-19. What COVID-19 has done, especially in the Western world, I think, is focused or forced us to focus our attention on the various inequalities that exist in society. There was a huge debate, and even now the learning continues about how COVID-19 affected people from an ethnic minority background in the UK and indeed in the Western world. So we will look at what inequalities have surfaced due to COVID-19 or become more prominent due to COVID-19, and how that has affected the mental health and well-being of children and young people specifically, and what risks that poses for suicide and self-harm in children and young people. Now, the Office of National Statistics in the UK is the body which collects data on a range of health-related measures, so health, social, and economic measures in the UK. And I'll present some data from there, so which is related to the UK context. And I have some brief data about the Indian context as well, about suicides in children and young people. Based on that, based on the numbers and the narrative, we look at what might be a possible template for good practice. What are the areas of training, supervision, competency development, and organizational working we need to look at in order to provide good care and prevent suicides in children and young people. So the emphasis also is on saying that while we need to take an organizational approach or a system-wide approach, there are things we can do at an individual level as well, both as members of society and citizens, and also as professionals. So each act, each thing that we do, decision we take, makes a difference at an individual level as well. And I think that's the message, that those small steps of building blocks can build up to something very big. And before I proceed any further, I just want to acknowledge that this is an emotive and sensitive topic. Talking about suicide in children and young people is not very easy to do. And for some of you, you might have had personal experiences, or somebody close to you has had this experience. So I appreciate that it can be emotionally triggering. And if somebody needs to take time out, please do so. So, as you can see here, children are the only future the human race has. So really vital that we do everything we can to protect their lives. So I'm going to start off by looking at some of the data and the numbers that we have. I mean, as I said, it's mainly from a UK context, but I'll relate it to some numbers in India as well. So RCPCH is the Royal College of Pediatrics and Child Health. And they have talked about the suicide rate is highest, in the UK. So there are 4 devolved nations in the UK, Northern Ireland, England, Wales, and Scotland. So within the UK, we have the highest rate in Northern Ireland for children and young people suicides. It's at 17.8 per 100,000 young people. And in England, it is 8.1. But you can see, these numbers are still significant. And the fact that we have children and young people taking their lives in these numbers, and globally, they account for 1/3 of all suicides, which is really something which, needs to make us stop and be appalled. It has to hit us hard that these are the numbers we are looking at. So that's the overall number. Overall, young men are more likely to take their own lives than young women. However, suicidal attempts or self-harm are around 3 to 8 times more likely in young women. So although the numbers who die are more amongst young men, the numbers who attempt are more in young women. And we can also see that roughly over the past 8 to 10 years, the suicide rates have risen amongst this age group. So this age group as a whole and across younger males. So the age at which children are taking their own lives is becoming lower and lower. And it is tragic to see that children as young as 10 are taking their lives. And the numbers have increased in the younger males and females across all ages. So this is the pre-COVID situation in the UK. And what you can see, which is a shocking statistic, I think, is that the rate among 10 to 24-year-old females has increased by 83%. Now, in the UK, because we wait for the coroner's inquest for a verdict of death by suicide is given, there is generally a time lag between the suicide itself and the official confirmation of suicide as the cause of death. So the information in the public domain tends to be around a couple of years later than what we know of. So there are expected figures obviously released, but the confirmed figures take a while to get released by the government. So, in 2018, the rate in females increased by a staggering 83%. Now, although the numbers of females who die overall in this age group are still less than the numbers of men who die, the rates have gone up. And there is something, I think, as we go further, that we need to be aware of and do much more of about what current lifestyles, society, and expectations are doing to young women in particular, and how that places them at a higher risk of suicide. But you can see that amongst males as well, there has been an increase in the range of around 25%. So the link between self-harm and suicide, now this has been talked about across all age groups, has been talked about more amongst adults. And we know that everywhere in the world, whether in India, the UK, or indeed in other places, there is a link and a dynamic link. So the more number of attempts that you make of self-harm, the higher the risk of suicide. The more serious the attempt, the higher the risk of suicide. So really important that when we see self-harm in young people, we intervene early with effective interventions and support so that it doesn't become a pattern of behavior for them to engage in self-harm when they are coping with unmanageable emotional distress. And in terms of self-harm as well, the rates have risen quite significantly amongst young people, particularly amongst young women. And this is a worldwide trend. So in England as well, in the UK, in fact, the rates of young women who've been self-harming has increased steadily. I think, the latest figures show that it has increased by around 15 to 20%. And in fact, when studies have been done about children in secondary schools, and on some occasions, they have found that around 45% of young women have self-harmed at some time as part of their school life. The other interesting thing, especially as we will be focusing on the inequalities which have been further exposed by COVID, is that the rise in self-harm was highest in the ethnic minority groups, so in the UK. And so that is significant because this group of people is affected by other risk factors like deprivation and poor access to healthcare. So we know these are overall risk factors for mental health problems, but they also then lead to higher rates of self-harm. So we are seeing that people from an ethnic minority background in the UK are showing higher levels of self-harm. And in India as well, we know when we look at various recent figures that the numbers of young people who are making serious self-harm attempts or taking their own lives is rising. So there was an important national report released in the UK in 2018. And for the first time, it dealt with suicide in children and young people. So this is released by the National Confidential Inquiry into Suicide and Homicide, which is hosted by the University of Manchester, which has been collecting data for the last 22 years. And for the first time in 2018, a report was released solely looking at children and young people's suicide, because it was, realized that it was a growing problem. So what they have found is that those who have died by suicide had some common factors, some themes which emerged. One was adverse childhood experiences such as abuse. So abuse of all kinds, emotional abuse, physical abuse, sexual abuse, which actually forms a big part of risk factors. And even the experiences of poverty, parental mental illness, childhood deprivation of various kinds, in inadequate access to school care. So the various levels of deprivation, neglect, and abuse that young people can experience can be a risk factor for suicide later on, if not addressed at the right time, and if steps are not taken to ameliorate that. And something which has become increasingly common, and in India as well, there's a huge focus now on the academic pressures on children and young people, so our teenagers, and relationship difficulties. So whether it is relationships with family members, conflict within the family, cultural differences. So I do not mean everyday arguments and fights, which happens, which is part of human interactions, but significant level of conflict at a consistent level, of a consistent degree over a period of time, which has a negative impact on relationships, where therefore the caring and the love is lost amidst the rising levels of conflict. So this is what I mean by conflict. So when there are these constant conflicts and relationship difficulties and academic pressures in young people's lives, and recent events such as bereavement. Now, in the context of COVID, we know that many children and young people in India, we've seen horrific stories about children being orphaned due to COVID. And generally as well, even before COVID, when children and young people experience bereavement, especially bereavement through suicide, it increases their own risks of dying by suicide later. So these are some common themes which emerged from that report in 2018. And if we look at the trends in India, now I've got some information about the trends in India. You can see that there are some common factors. So firstly, the thing which is really striking is that an Indian study showed that the suicide rate was highest in the 15 to 29 years age group, 38 per 100,000 population, followed by the 30 to 44 year age group. So in recent years, so this is over the last decade or so, the rates of suicide in India amongst young people have risen, and they now form the commonest age group at which people die by suicide. So that's actually worrying for us. I mean, both in the UK and in India as a society, the fact that rates are rising in this age group and are forming such a big part of people dying at this age, is really something which we all need to take very seriously and makes us sit up as to what is it that we are doing as a society to our children and young people that is placing them at such unimaginable levels of stress. So in India, the suicidal behavior was found to be associated with the female gender, not attending school or college, independent decision-making. So you can see, based on the risk factors mentioned here, that there is commonality. So when young people have those conflicts, find it hard to have their own sense of agency, are not able to be involved in their own decisions, don't have proper access to school or college, or have academic pressures, they experience abuse, physical abuse and indeed sexual abuse. And, I think in India as well, mental illnesses not being diagnosed and treated at the right time can have an effect on suicidal risk. And this has been seen as these are some of the risk factors, or these are some of the common factors that have been seen in young people who have died by suicide. So we know that in India, poisoning is the most common method of dying by suicide, and that is reflected in young people's figures as well in terms of the methods used. So coming back to suicide in children and young people and COVID-19. So we've looked at some of the things that were happening pre-COVID, some of the data, the numbers, both in India and the UK. So when we look at what's been happening due to COVID, now what was found in the UK in the early stages of COVID was that there were what we call concerning signals. So these weren't statistically significant rises in suicide rates in children and young people, but it was felt based on informal data, based on reports, etc., anecdotal reports, that there might have been a higher rate of suicide in the initial months of lockdown. So when the UK went into complete lockdown the first time, March to June last year, there were concerns that the suicide rates had increased. But ultimately, when the report was released in December 2020, it was realized that the numbers were too low to make any firm conclusions, and they were not statistically significant. But we know that the risk factors associated with suicide went up. What we also know is that when there are major public disasters, whether they are pandemics or wars or of any other major public or global disaster or crisis, the impact of it is felt for several years. And we are not always able to comment on it in a year or so after it has happened. So I think we need to watch the space very closely and see what happens to the trends of suicides in children and young people over the coming years. So amongst the likely suicide deaths reported after lockdown, so, when the reports started coming in, so restriction to education and other activities, disruption to care and support services, tensions at home, increase in domestic abuse. So when people were cooped up at home together, when people weren't able to have access, whether it was to social services, police, hospitals, A&E, the impact of domestic abuse and violence at home was felt. And these are all contributing factors. And what has also been seen in the UK, and in fact, it's come out even in the latest study we were discussing last week, actually, is that the risk is high. The risk of suicide for children and young people who have either an autistic spectrum disorder or ADHD is increasing significantly. So this has been found to be a factor in around 25% of young people who have died by suicide. So again, we need to be aware of the effects of these neurodevelopmental conditions on children and young people and their risk of suicide. So we've looked at the numbers, we've looked at some of the initial signals around the impact of COVID-19. So I'm now going to delve a bit deeper into how COVID-19 and inequalities as a whole have affected the mental health of children, young people, and families, and how that has led to an increased risk. So please bear with me as I expand on some of the points that I have mentioned already. So as I said earlier, what COVID-19 really forced us to do in the UK, and I think similar conversations are happening, in different parts of the world, is what are we doing about the inequalities in society, and has forced us to acknowledge how deeply entrenched some of these inequalities are. So talking from a UK context, some of the things which have come up and forced us to peruse our role in all this is, the Black Lives Matter movement, which became a global phenomenon after the murder of George Floyd in the United States last year. The inequalities which were revealed by COVID itself. I mean, as Dr. Shankar said, in the first phase of the pandemic in the UK, 95% of doctors who died due to COVID were from a Black, Asian, or minority ethnic background, BAME background. And overall, over the last 18 months, up to 65% of all healthcare workers who have died, so whether it's doctors, nurses, pharmacists, allied health professionals, have been from a Black, Asian, or minority ethnic background. And this is reflected in the population as well, where amongst the various groups, so in Black Africans, the death was around 4 times more than the white population. Amongst Indians, it was around 2 times more. Pakistani and Bangladeshis around 3 times more. So amongst all ethnic minority groups, the death rates by COVID, and in fact, the rates of hospitalization and ICU care were much higher amongst ethnic minorities than the local white population. So COVID itself affected different ethnic groups differently. We also have seen in the UK the effect of Brexit, some of the intolerance, some of the heightened tensions between communities, and the impact it had on people's livelihoods, academic careers, people being separated from their families. So again, the differential impact of it was felt differently by different groups in society. Even the whole issue of vaccine access and the take-up of vaccine has seen inequalities being played out. So in the early stages of the vaccination program, when people from ethnic minority backgrounds expressed concerns and showed hesitancy about the vaccine, rather than understanding and engaging with them and trying to work with them to understand their hesitancy and their reluctance to take the vaccine, there was a lot of blaming and shaming about why they weren't taking vaccine. So once again, the approach was very different to when a member from an ethnic minority background was refusing vaccines. I mean, the point of all this is, whether it is about Brexit, whether it's about the vaccine differential impact, whether it's about children who are refugees, asylum seekers, the fact is there are some groups in society, even amongst children and young people, who bore the impact of COVID disproportionately. And they felt the impacts of COVID on their mental health much more. So children and young people with autism, for example, found it very hard because of their need for structure, for routine, for predictability, and all that was lost during COVID. So the impact on their mental health was very significant. It had some particular implications for them. So these are some of the things we've learned during COVID, and we've seen affect the mental health of children and young people. So further looking at the detail about how it has unequally affected the mental health. So COVID has unequally impacted on the mental health of children and young people. And we are seeing that in terms of referrals to our services. So the referrals in children and young people's services have shot up by around 20%, and in some cases by 50 or 60% in some parts of the country. So we are seeing a very significant rise in the referrals, in the complexity of presentations, in the acuity, in the crisis that they come in, and the need for inpatient admissions when children present with mental health problems. So we are seeing that. We are continuing to see that, and I'm sure we'll see more of that as time goes on. So as we've discussed, in children, we can see that the impact of school closures and illness within their peers at school, that has had a very disruptive effect, because schools would be closed at short notice, or their groups or their class groups would be closed at short notice. Everyone would be asked to go home, and you never knew when you would either become COVID positive or somebody in your group or bubble would become COVID positive. You had to isolate, your family had to isolate. And so there's constant interruption to education, along with the anxiety and the uncertainty as to who would be next, what it meant for the parents if they couldn't go to work because their children were ill or isolating. So this whole impact of school closures was really having a huge effect on mental well-being. And similarly, COVID illness in family or carers. So if parents, grandparents or carers became affected, either children didn't get the care they needed because their parents were ill or in hospital, or they suffered bereavement because they lost their main carers. Again, unemployment, poverty, and insecurity. Within wider society, of course, as a result of COVID, with all the closures, when there were lockdowns, shops closed and all commercial enterprises closed, people lost their jobs or they were uncertain about their future. And what we have seen in the UK is that the unemployment rate is highest amongst the 18 to 24-year-olds. So young people who are just trying to get into work after school or college found the biggest hit in terms of the unemployment rate. So again, it has affected their mental health. The social isolation. Now, all groups, it's important for all age groups to have access to peers, social relationships, etc. But for children and young people, it can have a particular impact. So we have seen the effect it can have when people are forced to remain indoors for prolonged periods and are unable to, although there is digital contact and young people are very savvy in the use of social media and digital media. However, being told that that's the only means of communication or contact and not having any control or agency over when they can meet face to face is a huge, it has a huge adverse effect. impact of bereavement and trauma, not only of losing their carers or parents, but losing their friends, colleagues, teachers to COVID, and what that can do to the mental well-being of children and young people. And the impact of increased social media usage. Now, all of us have had to rely more on social media, and digital connections became the only way of connecting with people for a very long time. And the impact of that, especially on young people, because they're already high users of social media. And as that increased, as that became their sole means of remaining in contact with the outside world, for them, the content on social media, which can, lead to shaming, whether it's body shaming, whether it is shaming about their gender and identity and about their academic performance. So all the negative impact of social media usage being compared unfavorably to peers, people talking about self-harm and suicide attempts online, all this is hugely detrimental, once again, to mental health. And as I have already mentioned, the impact of increased domestic abuse. Now, for some children and young people, there was also an increase in caring responsibilities. Obviously, if parents were ill, were in hospital, had died, the children became responsible for the care of their siblings or grandparents or whoever it was. So young carers are a recognized at-risk group now in the UK, and I think in many parts of the world. So the numbers of children and young people who became young carers. So instead of, we call this the phenomenon of the parentified child. And so children had to become parents very quickly. And that again has an impact on your well-being. Some of the other ways that children and young people were affected, for example, was digital poverty, food poverty. So by what we mean by this is, of course, everybody has some kind or the other of access to digital means. But if you are relying solely on your mobile phones or iPads for education because the schools are closed, unless you have the right devices, unless you have the right connectivity, internet support, etc., it's very hard for young people to continue with their education, for instance, or even continue being in contact with others. So in many parts of the UK, we've seen that there was an inadequate access to digital means to enable them to live their lives and get access to education. And similarly, around food poverty now, in developed countries like the UK, we've seen a soaring increase in the need for emergency food parcels. And I'm sure in India as well, because children were left either alone or orphaned due to COVID-19 and services not being able to reach them, hospitals being overwhelmed with COVID and therefore unable to look after people with non-COVID conditions, and then they died. So children didn't have access to parents and therefore food and, means of sustenance. So there are several children in the world who have been directly affected by COVID and the impact it has on, basic things like food and housing. And the Lancet has written several articles on the differential impact on mental health. And what it said is that by late April 2020, mental health in the UK had deteriorated compared with pre-COVID-19 trends. And what it had seen is that women, young people, and those with preschool age children were differentially impacted. And if we had to make a difference, we needed policies which emphasize the needs of these groups of people in order to ensure that their mental health was safeguarded. So what the findings suggested is that being young, a woman, and living with children, especially preschool age children, had a particularly strong influence on the extent to which mental distress increased under the conditions of the pandemic. So once again, you can see that various groups of people, along with those who lived in low-income homes with pre-existing health conditions and people of Asian descent, were disproportionately affected in terms of their family health as well. So the loss of social supports and networks, which we have looked at, all these factors were affected. And we've seen the numbers of looked after children. So those children in the UK who are taken into the care of social services because they have no parents or parental figures to look after them, increased during COVID times. And this, again, we know that studies have shown that amongst those children who are looked after, especially those who are in residential care rather than in family or foster care, the prevalence of mental illness is around 40 to 45%. So 40 to 45% of children who are looked after by the state have some kind of a mental health problem or mental illness or a neurodevelopmental condition. And this equates to anything between, around 12% in the normal population. But in the looked after children, this goes up hugely. And the numbers of looked after children increased during the pandemic. We've talked about the various traumatic impacts that COVID has had with bereavement, post-traumatic stress disorder, abuse, and the discrimination experience, whether it was racial discrimination or discrimination of other kinds. Again, the impact it had on young people and their mental health. So when we look at all these various adverse factors, including economic downturn, the difficulties with accessing healthcare, increased access to suicidal means. So when people are able to have, nobody's monitoring their access to medications or, to means, whether it is even substances which are misused, like alcohol, substance misuse, etc. When people are not being monitored or supervised for access to these things, then their chances of using them as a means of self-harm or suicide are increased. And this is what was seen in children or young people who were left largely to their own devices, either because parents were ill or had died or had to go out and work while the children were homeschooling. So this meant that they had more access to means of suicide. Inappropriate media reporting. Now I think there is perhaps more of a recognition as to how the media needs to be more responsible around reporting of suicides. But sometimes it's sensationalizes it. And that can have an impact, what has been called copycat suicides or the peer influence of this. So amongst young people, if they read about suicides by other young people or celebrity suicides, for example, it can have a triggering effect and, make them attempt to take their own lives. And the other thing, I suppose, amongst all this is also that while people were dealing with the pandemic, with the COVID infection itself, the acute physical health care became the point of concern or the focus of concern. So access to mental health services became difficult, at least in the initial part of the pandemic, because all the hospital resources were directed towards COVID care. And some wards had to be closed down, clinics had to be closed down, some went remote and people didn't always feel comfortable accessing remote clinics. So now the situation is, people are, the mental health care is catching up and the demand has increased as well. But there was a period when access to mental health care became very difficult. Even now, although mental health care is, services are working at full tilt, because the demand has increased, the waits have increased as well. So this has an impact on how whether you can intervene early at a young person's mental health crisis. If that early help is not available, things fester and grow, and we know that that can worsen outcomes and worsen suicide risk as well. So the increase in depression, anxiety, post-traumatic stress disorder, substance and alcohol misuse have all increased. And in young people in this country, there was also an increase in eating disorders. Now, that has been a particular area of concern, and we know that it can increase overall mortality rates. It is the mental illness with the highest mortality risk. So the prevalence of eating disorders has increased, and that has led to more children dying, although not necessarily by suicide. So I think, having looked at this picture, we've looked at the data, we've looked at the context, the impact of COVID, the various ways in which inequalities and trauma can play out on children and young people and family life. I think we are at a crossroads, and this applies across the UK and India. This is a make or a break moment. We can look at what the devastation of COVID is, how awful it has been, and say to ourselves, never again will we let ourselves get into this situation, and we can do something to safeguard the futures of our civilization, societies, and our nation, and look after our children and young people. So in the UK, there is a suicide prevention strategy which covers all age groups. But along with that, there's a 5-year forward view for mental health. And there is also a national report produced on suicide prevention every year by Parliament. So there's a parliamentary update on the National Suicide Prevention Strategy. And they have an ambition of reducing the suicide rates by 10% every year and ultimately reaching a rate of no suicides. Now, the term zero suicides is a bit emotive and I think not always helpful, but the ambition to continuously reduce the rate of suicides is a laudable one. Now, I know in India as well, there have been talks and there are a lot of discussions about a national suicide prevention strategy. And while there have been initiatives taken at local levels and institutions, recognized mental health institutions in the country are working towards it, I think a national suicide prevention strategy encompassing all age groups would be really a way forward and would focus the minds of governments and organizations to make sure that there are the right steps in place. So what that will need, so when we do have a policy, what that will need is a combination of the right training and supervision, research into means of preventing suicide, the right commissioning or the funding arrangements for these services, the right governance, that is, how are we monitoring, reviewing, auditing these services? How are we learning from things that have gone wrong? How are we learning from serious incidents? And then the right model of services. How are we organizing children and young people's mental health services? So these are all the infrastructural elements that we need if we are to make headway in providing the right care for the mental health of children and young people. So in the UK, there's something called the competency framework, which helps to enable people to learn the right skills and competencies. So it's right from having the conversations required. So what kind of therapeutic conversations do you need? How do you establish that trust and build a therapeutic relationship? How do you share information? How do you involve families and carers? And how do you maintain confidentiality and retain the trust of young people? So it talks about a range of competencies that professionals need, and the need to work at system level across various agencies. So in India as well, there is increasing work now between schools and mental health services, because people recognize that schools are a source of stress. Schools and academic pressures are a source of stress and risk factors. But B, they also provide a source of intervention. School teachers, if they are enabled and if they have the right training to identify early signs of mental health problems, can work closely with families and children because they see them every day for several hours. So the importance of working across systems, across agencies, with social care, with voluntary agencies. So all these are mentioned in the competency frameworks. And also one important thing about managing transitions between services. Now in the UK, we find that when children and young people are moving on from children's services to adult services, sometimes they can fall through the gaps. And it's really important that if we do have these specialist age-related services, that there are smooth transition pathways across the age groups so that people don't fall through the net. So as I've mentioned, the range of competencies that people are required to build on, professionals, are ranging from therapeutic conversations to safety planning. So being proactive about what can we do to keep you safe? What are the things you can do? And everybody being aware of that. So rather than risk planning, safety planning. Information sharing, I've mentioned. I mean, in the UK, it gets us into a lot of hot water sometimes because the notion of confidentiality is very firmly entrenched, rightly so. It's really important to build trust, but that shouldn't be a barrier to sharing information with parents or schools or other relevant people if that is a means of saving a child's life. That shouldn't become a barrier. So information sharing does have some guidelines which helps people to share information when lives can be saved. Now, those of us working in the field of mental health and psychiatry know that risk prediction is an inexact science, inaccurate, not very reliable actually. So we really need to be mindful of not placing not overemphasizing a risk assessment as being the only thing that will help us determine whether a young person will take their life by suicide. So while we need to look at the risk factors, we also need to look at their overall clinical presentation, their needs and their strengths as well. What is it that can help them reduce those risks? So just being aware of the limits of risk assessment, but the importance of having a structured approach. A big part of the suicide prevention strategy in the UK, and increasingly so, is becoming one of supporting those who are bereaved by suicide. Now, it has been recognized that they are at an increased risk of death by suicide. So those who are bereaved by suicide are at a higher risk of dying by suicide themselves. And the cost it can have, the impact on their mental health, the impact to society, their impact on their quality of life, their productivity is huge. So people are increasingly recognizing this. And in the UK, they are trying to constantly improve. And this is something I think we can work on in India as well, because, given the numbers, there is a huge group of people there bereaved by suicide who might not be getting the right help. We are not there yet in the UK either, but it is recognized in the strategy, which I think is important. I've talked about the importance of learning from serious incidents. So when people die, when things go wrong, how do we as professionals come together and reflect on what we can learn from that? What can we put in place? So having a framework to do that, and having space in our working lives to come together to reflect, is really important. It's not only important for the purposes of saving future lives, but for the professionals themselves. In the impact of suicide on a professional is very significant. And perhaps when I say we, it is India and UK and worldwide actually, we don't pay enough attention to what we need to do as professionals to support ourselves or one another when we are faced with a patient suicide. And so that doing that can also help keep the well-being of the doctor concerned also. And one of the causes of stress, burnout at work can be not getting the right support when serious incidents have happened and being blamed instead. So what can we do at an individual level, wherever we are, India, UK, become more aware of the issue, become informed, self-informed. So rather than waiting for other people to tell us, go out and seek the information, look up information leaflets, websites. And what we can do as organizations is collect reliable data, whether it is about inequality. So what are the needs of this group of people? Do we have the right data? Do we know whether rates are increasing, decreasing, static? What has helped? So collecting the right data is really important. Having a think family approach. So sometimes we try and improve the mental health of children and young people in isolation. But it is when we think about the family as a whole that the best results are seen. So having a think family approach is really important. And this is wherever we are, the UK or India, that approach towards the whole family really important. Having the right people in decision-making positions. So rather than it being a management decision, financial decision, making sure that the right clinical leaders are there when we are making decisions about services and funding, etc. And something which we are trying to do in the UK and would be good to know what the situation is in India is working directly with children and young people themselves, because they are very articulate, very well informed. They know what is happening to them. And when you involve them in creating solutions, that empowers them and actually makes us come to the right decisions regarding what works. So involving them directly along with involving their carers is really important. And, we've touched upon these points, the importance of staff well-being, supporting carers, having the right level of interventions, not only individual assessments, but group therapies, group counseling, group work, making full use of digital technologies. COVID has given us that. And let's not lose the advantages of the reach of digital technology. And that can be used in a very productive way to enhance the supports we offer children, young people, schools, parents. So enhancing the digital reach. So I think in India, one of the things that's come out through various reports and literature is the rates of diagnosis and treatment of psychiatric disorders can be an issue. So, and we know that treating mental illness in a timely way can help save lives. So amongst children and young people as well, we need to think of how we can increase access to, early intervention, diagnosis and treatment. The stigma of mental illness is there worldwide in some societies and countries more than others, and that can prevent people from seeking help. So by treating mental illnesses at an early stage, we reduce the risks I mentioned about having a national strategy and raising awareness, looking at what we can do about academic pressures. It's a national conversation we need to have, both in the UK and in India, as to how are we helping the young people deal with academic pressures, and what are we doing to reduce those pressures on young people. Again, I think a lot of awareness raising about gender-based violence, the role of those who perpetrate violence rather than victim shaming or blaming, and how do we tackle these issues as society. Very important, the role of social media. Now, these are things not only at a national or institutional level, but things we can do individually. What am I doing? How am I using my social media approach to reach? What am I doing to combat gender inequalities? What are my values, culture? What am I doing to make sure that I'm dealing with the academic pressures of my children? So there are things we can do at an individual level as well as at a wider level. So, for people who think that this is too big a task, that there's quite a lot to do, we're not sure whether we'll get there, we need to remember that one person's action sometimes can make a huge difference. In India, in the UK, a footballer called Marcus Rashford, some of you might be aware of him because if you follow football and Manchester United, but the more important thing is, as a footballer, he single-handedly changed the government's policy on free school meals for children and ensured that during COVID, those children who are being deprived of at least one nutritious meal a day continue to get it. So one person can indeed make a difference, and change begins with that one person. So just want to put that out there. And also I want to just mention Samaritans in the UK, and I know there are similar helplines in India as well, about reaching out and, picking up the phone and talking to someone at the end of a phone. So they are complete strangers to you, but they are willing to listen and help you out of a crisis. So as a single person, at an individual level, you can make a difference. You can pick up the phone, make that first call, save a life, help someone. So let that not deter you. You can make a difference on your own, but there are things we can do organizationally as well. So I finish my talk there. Very happy to take questions or comments. Thank you.
Anita, your questions on your chat box, could you please read them?
Okay, let me see if I can read them. I don't seem to be having, at least I can't see the questions in the chat box. Let me see if I can see them. I'm sorry, I don't seem to be receiving the questions in the chat box. Is it possible to read out a couple of them, please?
I will.
Thank you.
The thing was, we had a study here in our institution where we were trying to assess the people who had been admitted with attempted suicide in the A&E, as you call it, and casualty, and also the ICU.
Yes.
And many of them were not able to correlate the pandemic with their social act at all. So what we thought was this pandemic was a distal cause rather than a proximal cause. That is, the pandemic caused some kind of a loss or a change in the circumstances, which happens to people usually. I mean, no, I don't say usually, sorry, that's the wrong term, which happens to people that causes the social act rather than the COVID by itself. So this, whenever it happens, I mean, for instance, a person has COVID and then he dies and the children are left behind or the youngsters are left behind. The loss of the father or mother is the proximate cause. COVID was incidental in causing the death of the father or mother. So we should be equating it with the death of the father or mother rather than equating with the COVID pandemic as such. That, because this is not my inference, but this is the information we had from people who had been admitted for suicidal attempts. Okay, that's one aspect I want to sort of comment about.
Yeah.
Okay,
Yeah.
can you comment on that?
Yes, of course. And as I've mentioned in my talk, I think, what it has meant is that people have not died directly due to COVID, but COVID has intensified the loss and the trauma that so many people have lost their parents and carers in such a short space of time. This does not normally happen in the normal course of events. In society, we do not have so many people dying at once and so many people children being left orphaned or without carers. So amongst the risk factors that I mentioned, trauma and bereavement is an important one. So for many people, that has led to a worsening of their distress, their mental health, and therefore increase their suicide risk. So you're right. It is not COVID-19 directly. It is all the fallouts or the impacts of COVID. What it has shown us is that these factors have occurred in a very short space of time at a very intense level. Normally, I mean, if you didn't have COVID, yes, children do lose their parents, children do, become isolated and orphaned, but it happens, at a much lower level within the country. Whereas now, in a very short space of time, millions of people were affected at once. And so the cumulative impact for so many children and young people has meant that, their mental distress has increased. But you're right. It is not COVID directly which causes suicidal ideas. Although I have to say, there have been several papers in the Lancet about how around 1/3 of people with COVID have suffered direct neuropsychiatric sequelae. So COVID most commonly causes a respiratory infection, needing ventilator support and sometimes an ICU admission. But we know that around 33% of people who have COVID have also suffered psychiatric symptoms or complications. And in the UK, long COVID is becoming something which is increasingly studied, which can cause a large number of mental health problems as well. But you're right, in the vast majority of cases, it is not COVID itself, but the impact of this huge and acute loss of carers and lives, which has led to suicidal attempts in children.
The other point you made was the long-term consequences of this particular COVID pandemic. That again, could COVID by itself can cause that particular long-term effect, or is it the proximate cause, which is something else? This is one observation. One question. Another observation is that in the second wave of the pandemic in India, that is, first wave was in the 2020, and the second wave was in the March, April time of 2021.
Yes.
Actually, a lot of middle-aged or early middle-aged people died. That is the age group between 30 and 50.
Yes.
And these people had left behind the children, and they were either orphaned or they had to be clubbed by the aged grandparents, which is not a good thing for them. And that will cause a lot of psychiatric morbidity, which has to be addressed, in my opinion. Thank you.
Yes, absolutely. And I think what people are saying in the UK and in India is that we will know over the next few years what the long-term impact will be. I think, most of, I suppose, in terms of the impact on mental health, suicide rates increasing, etc., it is not COVID directly, but the, impacts of COVID. But one of the things which is being studied, at least in the UK, is long COVID. I mean, in the Western world, it seems to be more prevalent, more studied. So we don't know what the impact of this will be long term. So, it is known to cause significant anxiety symptoms, depressive symptoms, sleep problems, and of course, a lot of physical symptoms as well. Now, we don't know what the impact of this will be long term on mental health and suicidality. That is something which is going to be studied. And so therefore, we can't comment on that now. But most of the mental health effects and the effects on suicide long term are likely to be due to the indirect causes of COVID, as you have said, being orphaned, very young children being orphaned, because people have died in their 30s and 40s. The children are still very young. So we are going to see the indirect effects of COVID causing long-term mental health morbidity. The social isolation, lack of access to peer groups, lack of access to education, uncertainty around their life chances. What will happen to me? Will I ever get employment? Will I ever be able to finish my degree? Will I ever be able to get married, have children? The uncertainty of the future is going to be weighing very heavily on children and young people's minds. So those indirect effects are likely to be more in terms of the long-term impacts. But I'm sure we'll be hearing more about COVID itself, long COVID, and the psychiatric symptoms of COVID. We'll be hearing more about that as well as we go along.
Thank you, Ananda. This is one of your passions, children and young adults. And your other passion is championing the cause of the disadvantaged in many ways. Can I request you to prepare a talk on that, and maybe we can, have a talk later on a symposium or something like that? Thank you very much. Anyway, thanks a lot for your contribution. Bye bye.
Thank you very much. Yes, very happy to come back in the future to talk about some of my work in the area of addressing inequalities and disadvantage. And thank you for inviting me and giving me the opportunity today. Found it a fascinating morning. I listened to the other talks. And thank you.
Thank you then. Bye-bye.
Bye.
Recording stopped.